So I'm thrilled to be part of the team to officially open the 2025 Baptist Health Orthopedic Care Symposium together with the Jamaican Orthopedic Association. Again, it's an honor to welcome this distinguished group of clinicians and colleagues united by a shared passion for advancing musculoskeletal care. And this symposium is more than just a clinical exchange. It's going to be a celebration of innovation, evidence-based practice, and global collaboration. Today's agenda reflects the dynamic future of orthopedics, from robotic joint surgery and tendon transfers to global insights in sports medicine. You'll hear from leaders who are not only shaping surgical outcomes, but transforming the patient care experience. Special thank you to the Baptist Health Orthopedic Care faculty whose knowledge and collaboration continue to elevate our standards across our system and beyond. And before we begin, I'd like to give a special thank you to Dr. Derek Papp, orthopedic surgeon, sports medicine specialist, whose leadership has guided this program from concept to reality. Derek, thank you for your vision and your tireless coordination and your support of Baptist Health International, and actually for bringing the idea to us. I appreciate it. We are also transmitting, and today we're recording. So folks are watching us also live. And at the same time, we will be having this available later on YouTube to share. So with that, it's my pleasure to invite Dr. Papp to the podium to offer his welcome remarks. Thank you.
Thank you. Yeah, good morning, everyone. I think this is it's a wonderful opportunity for everybody to get together. I was honored, I don't know how many years ago it was, to go speak at TCOS, and I've made a group of wonderful friends. Very quickly, it became my favorite meeting to go to. So welcome and thank you for coming. It's an honor having you guys here. Seeing the camaraderie that these guys have when they have their annual Lyme is fantastic. For the American surgeons in the group, a Lyme is an opportunity to get together and actually have like real conversations. So it is, again, very, very much an honor. So thank you for coming. Working with Roy Cardoso, it's been great. He's a fantastic partner, great person to work with. And again, he deserves as much credit as I do for this. When we envisioned this, you know, our goal was to bring everyone together, get everybody in a room and start talking, be able to talk about orthopedics in a real sort of manner, a way for us to just talk about the things that we like, real questions you have, be honest, you know, if you have complications or whatever, don't hide them, just talk about it. So again, hopefully we have a great group of speakers today. Like Dr. Ribas was saying, we'll talk about robotics, we'll talk about nerve and tendon transfers. The foot and ankle people have great stuff to talk about as well. We've got tumor and sarcoma, and basically everything Baptist has to offer. We're going to try to do it in a very concise way, so I'll shut up and sit down. And Roy, take my place.
Morning, everybody. Thank you all for spending the morning with us. To echo what Dr. Papp had said, a couple of things that were remarkable to me when I went down to the Caribbean a few years ago, and I've met all of you down there before. Number one is how easy it was to feel welcome down there, and I really appreciate that. I've made great friends and colleagues, and I think I've benefited just as much. Hopefully you've benefited from the collaboration, but the collaboration has been fantastic. So it's an honor to have you guys back with us. And then the other part that he talked about, you know, when you guys have these meetings, is the honesty, that conversation. So it's all well and good to present something, but like you guys talk about your complications and you talk about how these things worked and everything else, and that honest dialogue, I think, is very refreshing in some of these meetings. So hopefully we can bring a little bit of that here. So yeah, enjoy the day. I hope you have a great day, guys.
Right, so I get the opportunity to moderate our first session. We're going to do total joints, and we're going to start off with Dr. Charles Lawrie, who's going to be talking about robotic partial knee replacement, precision that performs. We might ask to change up the things a little bit because one of our speakers is running late. Yeah, we'll see.
All right, thanks, Derek, and thanks to the Baptist International Group for having us, putting this together, and the surgeons for traveling. Excited to see y'all here. So we'll get the talk booted up here. I'm Charles Lawrie. I'm one of the total joint surgeons here. I'm assistant director of the fellowship. And today I'm going to be talking about a robotic partial knee replacement, which has really been a total game changer in my practice in terms of partial knees. These are my disclosures. None of them are relevant to this talk. So I do quite a few cases, a lot of primaries, a good number of revisions, and my uni practice has grown over time. It used to be maybe 10, 20 a year, and now I'm doing 75 a year. Hopefully I get that up over 100 at some point. And the addiction for me is that these patients really just do so well. I mean, they're like total hip patients. You see them in the office 2-3 weeks later, and they're already asking you when they can go and hit the golf course, whereas the total knees just tend to lag behind a little bit, even though we are getting better, as Dr. Vanderven will talk about. So, as I alluded to, why partial knee replacement? There's plenty of data out there showing that these partial knees recover at a much faster rate than total knee replacements. Looking specifically at residual symptoms after surgery, partial knees typically have way fewer residual symptoms, way fewer, it aches a little here, it hurts a little there, I can't do X, Y, or Z. They recover. There's a new paper showing they recover as good or better than total hip arthroplasties, which is generally regarded as one of the best recoveries in orthopedics. What are the advantages? I apologize for the busy slide, but there are just so many advantages of partial knees. I wanted to fit them all. Reduced OR time, decreased blood loss. The surgery is truly less invasive because compared to a total knee, we're not subluxing or dislocating the tibia from the femur. We're not subluxing the patella overlaterally. This is truly MIS surgery at its finest on the knee. We're retaining all the important structures the sports medicine surgeons care about, like the ACL, PCL, the lateral and patellofemoral compartments that help drive more normal knee native kinematics. We're preserving bone stock, potentially important in younger patients where we're thinking about maybe future surgeries. The knee feels more natural. These patients score higher on their forgotten joint scores. They have improved functional scores. They are generally more satisfied if you ask them, are you happy with your surgery, yes or no? More of them will say yes to that question. Complications also are far less frequent, and when they occur, they're far less severe. There's even some data showing that partial knee replacement has a lower risk of mortality postoperatively versus total knee replacement. So I would just poll the audience here, given all of that, which of you wants to sign up for a total knee and which one wants a partial knee? Why aren't we doing more total partial knee replacements? This is kind of the bad and the ugly. I just showed you the good. Partial knee replacements traditionally have been plagued by complications that were higher than total knee replacements. And that was really because the manual instrumentation that we use for partial knee replacements is not great. The exposure is not great. We're making smaller incisions. And if you combine those two things, instruments that aren't great with something you can't see what you're doing, obviously that's a setup for a disaster. There's 6 degrees of freedom when we talk about putting the knee replacement components in, the varus valgus of the component, the flexion, the extension, the rotation. If you take each of those 6 degrees of freedom and you pick a target value and you say, I want to be within plus or minus of that target value, there's actually 729 possible outcomes given all those degrees of freedom, and really only one of those is theoretically correct. So that consistency of achieving that 1 in 729 is virtually impossible with the traditional instrumentation. This was work that I published when I was at Washington University in St. Louis, showing that our manual unicompartmental knees that had been done in the past had a very variable alignment of the tibial and femoral component. This is radiographic outcomes. Only 19% of cases hit all of the target alignments plus or minus 2 degrees. Looking at survivorship, this was a private practice surgeon who was in St. Louis as well, who was brave enough to publish his results. He had a 2% revision rate at 7 years of his partial knee, and then a 13% revision rate at 5 years. Sorry, those total knees were the 2% revision rate, and the partial knees were 13%. So you can see remarkably higher revision rate of the partial knee replacements. What was even more concerning with his work was that he showed that over time, his failure rate did not improve with the partial knees. So no matter how many of those surgeries he did, he continued to have a failure rate that was unacceptably high. So we've seen great outcomes published by the Oxford surgeons in England showing that They don't have any problems. All of their partial knees survive over 20 years. And this was a commentary published in response to that paper from the private practice surgeon saying that the implant developers may have mastered a technique that is not transferable to smaller centers. So even a high volume knee replacement surgeon, talented surgeon, did well with total knees, struggled with partial knees, and had a high complication rate, which I could tell you that was my same experience doing partial knee replacements with manual instruments. So what is the role of enabling technology such as robotics in arthroplasty? As Dr. Vanderveen will follow me here and talk about total knees, but specifically with partial knees, we're improving our accuracy and our precision. We are reducing the problems associated with poor component placement and potentially more. So the advantages of robotics, we're able to plan more precisely. We're able to modify our plans during surgery by feeding the system intraoperative data about that patient's knee. And then we're able to execute our plans extremely precisely, and that drives better patient outcomes. So I'll just walk you through the workflow here. I use the Mako robot for my partial knee replacements. I think it's the most advanced robotic system on the planet for these procedures. Basically, the patient obtains a special CT scan at a center that's doing a CT protocol that the Mako needs. It includes the hip for center of rotation, the knee for the 3D anatomy of the knee, and then the ankle so you can align get the limb alignment data. The images are segmented. This used to be done by hand, but they're doing it now more and more by automation and machine learning AI. Creates a 3D model of the bones that during surgery, we are basically going to take the patient's knee and register it to the computer model. So the system then knows where that patient's knee is in space. And then we as the surgeons, like I said, can feed that system intraoperative data and then precisely plan in 3D how we want to position those components based on the outcome we want to achieve. So this is what a pre-op plan looks like. Typically, we have a product specialist that Stryker provides us that will create these pre-op plans. We can walk into the operating room and tweak them as we see fit. So potential efficiencies here in like an ambulatory surgery setting where you could already know what size components you're going to place into that patient. I typically open my components before I even start the procedure. They're already open on the back table. I never change the size for the partials based on the plan. It's extremely accurate. Once we start the procedure, the incision is typically a fairly normal incision. We place femoral and tibial tracker arrays. That is how the robotic system is going to know where that knee is in space. There's a camera system that then watches these arrays. We're going to rotate the patient's hip around in circles so the robotic system can then capture where that patient's hip center is. We'll register the bony surfaces. So again, the system knows where that patient's knee is in space. This is a sharp probe that we take through cartilage down to bone in a pattern specified by the system. And basically, we're going to collect a bunch of different points all over the surface of the patient's native knee. And the camera and the robotic system together with us picking correct points are then going to teach that robot where that patient's knee is in space. We have a verification system that follows the registration, basically where we touch the pointer probe to the bone in various areas, and we call it popping the bubbles. You saw those blue bubbles turn white. It'll show us how many millimeters away from the bone that probe is in various areas. And then once we have things registered, we will take the native knee through a range of motion and then stress the knee. In the partial knee situation, we usually just put a valgus stress on it, so stretching the medial side of the knee in flexion and extension to see where that knee is tight and where it is loose. We get these graphs, like here on the top left, showing us throughout that range of motion. The x-axis is the motion. The y-axis is how many millimeters of laxity we have on that medial side of the joint. And using that information, we can precisely plan where those components are going to go to provide the optimal balance for that patient throughout their range of motion. So if you're a little tight in extension, but you're loose in flexion, you can change the component position to make the laxity equal throughout the range of motion. It also will show you, if you look at the yellow interposed in that center picture over the green, that is where the cartilage is. If you take a probe and run it over the cartilage, It'll show you where the cartilage is relative to where the implant's going to be, so you can plan a smooth transition of the implant going to the trochlear cartilage there. And then finally, you can see where the implants are going to be tracking relative to one another. So that's the picture on the right, where you see that tracking line is more or less going straight down the femoral component. That's where the tibia and the femur are actually going to articulate. So this is just showing you a video of what that kind of looks like in real time. The screens look busy, but your brain gets used to it after you've done a few of them. And we can scroll through the CT scans. I mean, we have absolute precision for where we are placing these components, which is, again, just incredible compared to the old instruments that we had. Once we planned, we go to the precise execution of our plan. So haptic guidance, I say this is like me holding my 5-year-old son's hand while he's trying to paint inside the lines. You know, like I will not let him paint outside of what he's planned on painting. That is what the robot's going to do. This robot will not let you resect bone outside of what you have planned. So it is extremely precise. We use a saw and a burr combined. So typically we start with the tibial cut. We're going to let it know that the correct saw blade is attached to the robotic arm here. And then basically the green is showing us what we need to cut. The green lines are showing us the haptic boundaries, which it will not let us go outside of those lines. And if we go outside of those lines, it shuts the power to the saw off. And then it's also a haptic planar, so it's going to keep us at the same resection, the appropriate resection depth, varus valgus, and slope that we planned. As we are advancing along that plane, it's showing us, you know, how much we've cut. If we cut a little too much, it'll go yellow. If we cut way too much, it'll show us red. And again, it'll actually stop us if we get out of bounds, so we can correct. This also helps protect the soft tissues. You still need to put retractors in, but certainly makes it much harder to cut things like the MCL or the structures in the back of the knee with these haptic boundaries. The posterior femoral cut similarly is done with the saw blade. You know, you can see here again, the haptic boundaries were captured by the plane as we advance the saw. The femur, the rest of it is finished with a burr. So the saw is more efficient, but the back of the implant that pairs with the system is curved. So the burr helps us create that nice curved shape on the distal femur here. And again, we're just trying to burr away the green. Once we're done burring, the implant has pegs on the back of it that help us get it lined up in the right place. So we'll use the burr to precisely position those pegs. And again, this is going to help us get that implant exactly where we planned it. Next up would be tibial pegs, similar to the femur. This is going to help put that tibial component precisely where we planned it. Partial knees, typically you put the trial on and it still has some wiggle room as to where it can go. Because we're doing the pegs before we're putting the trial on, the trial is going to go exactly where we planned it in the system. Once we have our trial components in, we'll again go to the screen that looks like the one we started with, and we can confirm the patient's alignment. We can confirm the range of motion. We can look at the tracking, all the same variables we could look at the beginning of the case. Here we're confirming at the end of the case. And I can tell you it's virtually perfect every single time, no changes needed. So highly efficient because you plan once, you execute once, and then there's no messing around at the end of surgery. You open the final implants up and put them in. Post-op x-rays, we joke around with the robotic partial and total knee replacements that we don't need to check our post-op x-rays anymore because there's just no foul balls. We know exactly what we've done, and the x-rays just validate that. So, you know, in summary, what's the case for robotic partial knee replacement? More accurate, more precise, fewer complications, leads to better survivorship as well as better outcomes. So we repeated that same study that we had done with our manual knees and looked up our initial series of partial knee replacements. And if you remember that slide from earlier in the talk I showed you, these dots showing the alignment of the cases looks a lot more clustered inside those green and yellow bounding boxes. And 91.6 were within all of our alignment targets as opposed to 19% with manual instruments. So that's quite a change. Complications, this is a recently published study from a group in Atlanta that if you look closely here, you can see robotic assisted partial knee is the second column, manual is the third column. All cause reoperations at 1 year were statistically significantly lower with the robotic assisted versus manual knees. And then same thing at 2 years, statistically significantly different revision rate with the robot versus partial knees, robot versus manual. Don't take my word for it, trust in AI here. I asked ChatGPT this morning as I was putting the finishing touches on this talk, what is the safest and most precise way to perform a partial knee replacement? And this is what it told me. Pick the right patient, use Mako, and use a precise technique. Thank you.
Thanks, Dr. Lawrie. Next up, we have Alex Vanderven talking about the Mako. Mako knee, this is not navigation.
Good morning, and I tried to chat GPT this talk, but I was not successful. I don't think it's ready for prime time, so we did put this together. Charles had a little bit of an easier topic because I think the standard of care is robotic partial knees. There is level 1 data to say that it is superior. The problem is for robotic knees, our level 1 data is not there yet. I have no disclosures relevant to this. In fact, I have no disclosures to Stryker or Mako at all. So all of this is based on my personal experience in this process. There's no doubt navigation is going to facilitate the complex primary knee, the previous hardware knee, the non-instrumental, the femur that can't be instrumented, or the conversion of the partial knee. This talk is not to give you any technical pearls. We're not talking about any of the technical side of surgery. We can save that from my colleagues. This is for the general basic orthopedic surgeon who wants to make their life easier. I am a late adopter. Everybody knows I'm a late adopter of technology. I'm the last in my group to use robots. And of all my colleagues, I'm probably going to be the one who's going to be using this robot more than anyone else as well. And so my experience on this is all just based on my painful process of accepting navigation, and specifically robotic navigation. And I'm going to give you 4 arguments why robots are better in comparison to the old navigation systems that I think a lot of people are familiar with. If we talk about navigation, Charles went over this. Basically, navigation in my terms is we're going to somehow map the patient's anatomy, specifically the femur and the tibia. We're going to connect it to some type of processor that's going to give us a digital readout of what that limb is doing in active time. And what we do with that information is really dependent on the navigation system. These have been classified as passive systems that just give you information, some semi-active systems where there's some actual robot that's involved, and then the fully active systems. These are the old systems that would actually mill. You'd turn them on, you could leave the room, 20 minutes later come back, they've done their task. Some of these navigation systems are based on previous imaging, whether it's x-rays or CT. Some of these have a patient-specific plan, some of them do not. These are just terms to give you kind of an understanding of where we are. And the traditional navigation systems, again, these are the ones that came out in the 90s. These were used in the early 2000s and to the early 2010s. We've seen different adoption rates nationwide and worldwide. Australia and Germany up to a third. The UK and the US were a little bit slower on this, and we would see regional differences on these navigation systems as well. And why would we use navigation? Well, if you look at failures in total knee replacements, which are not that common, but common enough at about a little less than 1% per year, we can attribute some surgeon-related factors to about 50% of the time. Specifically, loosening and instability are probably some technical factors. Whether they occur late, whether they occur early, I think the community would agree that some optimization of these things can mitigate these complications. And so we know that malalignment of more than 3 degrees or malcomponent positioning of more than 4 degrees will lead to premature failure. Also in the sagittal plane as well, slope and flexion of the components can also lead to failure. And so we know that outliers were part of manual knee replacements. And anybody who says they don't have that is obviously not really operating on people. And so although they may not be so common, we have opportunities to mitigate those outliers, and that's where navigation really came to play. And so the multiple papers came out to prove that we can limit those outliers. We can limit those 3-degree variances. And so this was the main argument for this excess costs and this excess time. And the meta-analyses support that navigation systems, traditional navigation systems, are going to limit those outliers. The problem is, did that correlate to anything other than outliers? And the problem is, it probably never did. And so after 15, 20 years of studying these navigated patients, we realized the patients may not be any better off. And so those arguments didn't really hold up. And the pitfalls on this were, there's still some variability in looking at the knee joint angles. We know that some small errors of where we find the knee center on the femur can lead to some errors in the overall alignment. The systems are somewhat cumbersome, putting in pins, closing those pins, pin site complications, mapping the knee without any type of CT-based system can be highly variable. We're not taking complete points. There's a technical side and there's a cost to this. And there's a learning curve. And I think a lot of surgeons tried it and were turned off by it. And to me, the final nail in the coffin came out in 22 when the Academy came out with clinical practice guidelines of surgical management of knee osteoarthritis, and they came up with recommendations which would, they would look at levels of evidence, and they basically threw navigation out the door with a moderate recommendation. There's no difference in outcomes, function, or pain between navigation and conventional knee replacements. And to me, when I saw that, I completely turned away from even robotics, because they subsequently came out with a recommendation that robotics also shows really no difference in function, outcomes, or complications, at least in the short term. Now, this wasn't such a high level of recommendation. This is a limited recommendation. And the problem is, these robotic systems were some of these semi-autonomous systems that, there's variations of what was out there, but a lot of these were not CT-based, and a lot of these had really not the processing speed that we've been seeing with the modern Mako. And so at that point, I would think most people threw away their navigation systems. And it's an amazing change that we saw. There was so much growth on such a field, and then within probably a few years, the system completely turned away from it. They were expensive. Again, the learning curve, the setup time, cumbersome, and we stopped. And so the problem with traditional navigation, and this is what we're seeing in the recent, at least in the last 10 to 15 years, the problem with it is that these were based on a mechanical knee alignment. And so for those of you who still remember how you did knee replacements, mechanical knees where you cut the tibia at 90 degrees and you'd match the femur to match the overall anatomic alignment of the limb. And that, in the last couple of years, there has been a shift, a paradigm shift, to no longer looking at the alignment, but to looking at the joint line itself and the obliquity of the joint line. And McDessie published in 21 the CPAC classification, coronal plane alignment of the knee, which I'm sure a lot of you heard about. And they came up with a very easy model, a very reproducible model, where they looked at 9 different classifications. The most common being the apex distal, meaning the joint line of the tibia is in varus. A neutral joint line would be obviously flat, and apex proximal would be a valgus joint line of the tibia, which is least common. And then they based it on the overall alignment of the leg, the varus, neutral, valgus. The most common being the apex distal, again, slightly varus joint line on the tibia. And if you look at the population, 75% of people fall into that first grouping with the varus alignment of the tibia. Second most common would be a neutral alignment of the tibia. And then the valgus alignment is almost never found. And so techniques of how we put these parts in, they've now characterized it. We've no longer gone with just the mechanical knee, which is the 90-degree tibia, but we've come up with really 6 different or 7 different ways of deciding how are we going to recreate the joint line of the knee, right? And so looking at just, we can now find these different techniques, and people talk about the kinematic alignment, inverse kinematic. We talk about the old anatomic knee where everybody was 3 degrees. And really what we're starting to see as the transition is we're starting to push to falling what the patient's native anatomy is. And this is where robotics comes into play. And this is specifically where CT scan-based robotics, because traditional, just mapping out a regular knee with a probe doesn't give us enough information. We need more points of information, and a CT scan can do this. And so my first argument for the advantage of the Mako is we can restore the joint line. Secondly, we all know these costs and reimbursement curves. We all know that the reimbursement per orthopedic surgery has been declining over the last 20 years. It will continue to decline. But we also know that the systems we work with, both the inpatient and the outpatient side of things, reimbursement is going up. And why is that happening? Well, there's no doubt this is being driven by Medicare, and this is being driven to align surgeons with their institution. And it's to allow the institutions to have a little bit more power over those surgeons. And this is the model we're facing, and it is what it is, and this is why we are all employed by Baptist, is because we're going to leverage these systems to help us deliver the care that we want to deliver, right? And so we have an opportunity to leverage some of that excess income that these systems are getting, and this is where we're allowed to start thinking about maybe do we want to leverage some of the technology to make our lives, which is our decreasing reimbursement, a little bit more palatable, right? And this decreasing reimbursements across all subspecialty lines, so everybody in this room understands that. And we've seen these growth curves of the demands of joint replacement surgery coming worldwide because the baby boomers and the advancements of technologies. And we're seeing probably, again, we're going to see a double the demand of joint replacement surgery over the next 10 years. But we're obviously not going to see the double number of surgeons. And so we're going to have to increase our productivity with our decreasing reimbursement. And so argument number 2 would be the incorporation of robotics, because this is going to make our life better. We're going to be able to deliver more care, and we're going to be able to do this more efficiently. We're going to keep up with the volume and speed. And there is no doubt that as we progress on our learning curve with robotics, we are faster because we don't have as many outliers. We're making less recuts. I still laugh because we have a senior surgeon who starts always with like a -4 cut on every, and everybody in the OR knows about it. And he has to make 7 different recuts on that tibia before he's committed to it. But robotics can take that away. In 1984, there was a book written, it was a fictional book called The Goal, and this was an operations-based leadership book called, and they talked about the bottleneck effect in factory work, and they called it the theory of constraints. And they found that the most successful factories, the most successful operations, the ones that have the least number of bottlenecks, the least number of weak links. And if you want to improve your operations management, you got to get rid of the weak links, right? You got to keep all of this stuff so there's no areas of failure, right? And if we think about traditional navigation systems, there are multiple, and when we do manual needs, there's multiple weak links, right? The question is, can we get rid of some of those bottlenecks and weak links? And so if we think about a traditional navigation, we've got an array that has to be placed, right? There's a human intervention. Then we have to map out that joint, right? Then we have to make some balancing questions of where we want to put the parts, right? Then we have to we have to drill a guide on, we have to pin it on. And then we have to use a manual saw to cut that, right? And so potentially you have 5 weak points in that supply chain of the delivery of a knee replacement, right? And if we think about what's going on with the Mako, we still have to put the array on, agreed. But then we're going to map that knee to a CT scan. So we're taking out already some human variability, and we're letting it fall back with a computerized backup system. And then we don't have any pins to put in. We don't have any cutting guides to put in. And then we have a saw that's also linked to a computer that's based on that. And so there really is almost no human intervention other than pushing the saw. And the reason why the Mako's been successful is because it makes it feel like the surgeon's actually doing the surgery, but the surgeon's not doing the surgery. The saw is doing the surgery. And so you've dropped that from potentially 5 error points to 1 error point. And so argument number 3 is CT-based robotics limits those variabilities in that supply chain. And then number 4 is balancing, right? We all talk about balancing knees. The Mako with CT-based backup allows us to virtually balance the knee before we start the surgery, to make decisions and to accommodate, to place the implants where we want to place them. And specifically, one of the problems with traditional knees is that one of the advantages of a traditional knee is we could use cement. And to me, cement was the greatest balancer of all balancing, because you make your cuts, you do your releases, the knee doesn't feel right. What do? We all know this. You put the cement on kind of sloppy, you throw it on, you extend the knee, and the knee balances. But the problem is we are seeing this transition is to cementless technology, which we know is going to be superior, especially in younger and harder bone. We've seen the growth in cementless technology. We want people to be able to run and impact on these implants. And robots allow us to make sure that we don't need that final cement correction to occur at the end of the case. And so my final argument is that robotics are eventually going to allow us to do a better job with cementless knees. I do worry a little bit in the future about our next generation not knowing how to do a manual knee. My children saw this telephone the other day, and they had no idea what it was for. And I realized they probably will never need to. And the question is, do our next generation surgeons really need to know how to do manual knees? And I have some, and I'm not sure that's the case. So anyways, that's exactly 15. Thank you, guys.
I think those were two great talks. It's similar question is, do we still have to ride a horse to work? We don't. So let me start with questions. So Mark.
I have a great talk, guys. Very good. But I have a question for Dr. Lawrie. In your talk, you spoke specifically about getting joint balance using bone cuts, correct bone cuts. Is that your sole method of getting balance, or do you try to get balance back with balancing the ligaments?
I think early on, when you start using these technologies, you default to your traditional methods and you release ligaments and do sort of traditional balancing of the knee. And then what you realize over time is that you can make, little 1 degree, 1 millimeter changes to the knee. And then all of a sudden you don't have to do a ligament release anymore. So, it's a whole other conversation in terms of, how much varus we'll put on a tibia, how much valgus we'll put on a femur, what rotation is okay. But as you get more and more comfortable, I think you start to expand how much you'll change the bony resections in the name of achieving adequate balance of the knee. This is for more simple cases. You get to the more complex deformities, I think or bad valgus, I think we're all defaulting more toward that mechanical alignment paradigm, releasing ligaments and trying to get the knee balance that way. But for maybe a 5-10 degree correctable varus knee, I think we're leaving those in a little varus and avoiding a lot of the soft tissue releases. And as a result, we see those patients recover quicker because we're not being as destructive or damaging during the surgery to their soft tissues.
Do you agree?
I mean, for total knees, I would say my inclination to do any ligament releases now has dropped by 90%. And it's now going back to a bony surgery versus a soft tissue surgery. So I think the idea of it being a soft tissue surgery has really changed. And I am totally fine. And I think we can balance the knee virtually before we make the cuts. And so there's really no more, I'm not doing those big, deep MCL releases. I'm not, there's a time I would be doing IT band and posterolateral corner releases. Sometimes I'm lopping off the lateral epicondyle and the severe valgus knee. We're not doing that anymore, even on these very severe knees, because we can error a little bit on the more valgus side. We can leave them, as long as their flexion gap is tight. I do think their extension gap doesn't need to be perfect, and I think we're seeing that with robotics. The patients are doing fine with that, with much less trauma to their knee.
Can I ask a follow-up question? Related to that, do you feel like people are getting better faster?
Yeah, absolutely. And I call it like the Goldilocks effect in the office. Like total knee clinic used to be painful because you'd walk in one room, it was like my knee feels too tight. You walk in another room, my knee feels great. And then you walk in the other one and my knee feels too loose. And now it's like everyone looks kind of the same coming across that clinic assembly line. So it's really been, quite enjoyable as a surgeon to not deal with that in the clinic anymore. And you know what you expect when you walk into the patient's room.
Yeah, I mean, for me, my biggest litmus test is my manipulation rate, which I keep very close tabs on to watch how I'm doing things. And traditionally with manual knees, I was at about 3%, and with the Makos, I'm down to 1.5%, which I'm so happy not to be doing those manipulations. But the other thing is that there's probably some bias because my confidence walking in the room is very different now than it used to be, because even though we do a lot of surgeries, we've done a lot of knees for the last 15 years, there's always that hesitation that could I have done something better? Could I have done something different? And now I walk in a room and I know I did a perfect job. If the patient's not doing as well, I'm probably eating a little bit less of that. And so maybe it's my perspective, but I mean, my objectively speaking, the manipulation rate has dropped.
Thanks.
For your total knees, are you doing PS or CR? And what's your rationale for if you go between?
Yeah, the question is between what kind of constraint do I use? And so I typically keep it a little bit open-ended. I'm not an all or nothing person. It's probably about 65% CR or some semi-constrained CS dish, and then probably other 35% is PS. It's really, to me, it's based on the flexion gap and rollback. If I'm seeing a pathologic rollback as I bring them from flexion to extension, and I'm seeing the anterior medial tibia falling close to the anterior portion of the femur, then I'm going to convert to PS on that, because I just think that rollback is really critical to the patient, especially with taking the pressure off the patellofemoral joint. That's just in my personal journey.
And what about the larger thighs? And what do you do for those, if especially like in a big varus deformity or?
Again, with the
Well,
we can treat them, we treat it, it's going to be treated the same. It's going to be based on alignment. It's going to be based on their CPAC classification. It's going to be based on their flexion gap. That's really my decision making. Yeah.
Sorry to put another spin back again on the balanced knee. Not all knees are the same. So I'm not speaking about the knee which may be in varus, for example, when they stand, and passively you can correct it to neutral. Not that knee. I'm talking about the knee which is in fixed varus, and passively you cannot correct it to the neutral position, anatomical alignment. Are you saying to me that you will use bony cuts to balance that knee or give you a good knee by only using bony cuts? Is that what you're saying to me?
So I will use bony cuts up to a certain limit. So for me, 5 degrees of varus on the tibia and 5 degrees of varus on the femur would be my absolute maximum that I'm ever going to leave that patient in. I had a patient, 20-degree varus, fixed deformity. I left him in tenovarus, and he told me his leg was straight. So like what we think is straight and what the patients think is straight is totally different. That being said, if I get to that 10 degrees of varus and someone who started with a severe varus knee that was fixed, and I still don't feel like I'm balanced, then I'll probably start doing more things like, stripping more of the medial capsule MCL off, maybe doing a medial tibial subtraction osteotomy to loosen things up. I'm not going to just cut the bone and then leave them unbalanced if that doesn't get me there. But I will liberally use those bony cuts in severe deformities to help me get almost all the way to the right direction. I think that minimizes the extra things that I have to do to get the knee balanced. And it sounds crazy, right? Leave a knee in 10 degrees of varus, cut a tibia in 5 degrees of varus. But, we got great data from Steve Howell with his kinematic alignment stuff showing that he can leave his tibias in 5, 6, 7 degrees of varus. And his outcome suggests that that doesn't have an impact on survivorship.
I agree.
I was hoping for disagreement.
No argument.
So I'll ask you guys both. When you talk about the learning curve, like how many cases did it take for you to get used to doing? Let's start with just a regular total and then like a partial.
I mean, the partial is easier. The published data on partial knees says the learning curve is less than 10 cases. And that surgery is truly, it is so easy. It is so reproducible. The total knee, I think I'm still in my learning curve, because I think you go down different rabbit holes, like learning how to do the actual procedure, learning how to put the pins in, learning how to look at the screens, like that probably takes 10 cases. But then you go down this rabbit hole of how am I actually going to balance that knee? Am I going to put the tibia in varus, or am I going to put the femur in varus? Am I going to rotate this much or that much? And I think that's what you're seeing a lot of the discussion at meetings and conferences is what is the target? Because now we have a tool that can hit the target, but none of us know what the target should actually be.
Yeah, and you know, on the I have a long history of triathlon. This has been my go-to knee for since I was even in residencies. We're talking almost 20 years of or 18 years of triathlon use. Only in the last 2 years did I start going to the Mako. So I know the knee very well. I do think it's a different, you know, this single radius curvature thing changes things a little bit. I think you need to keep the joint line a little bit lower than with some competing systems. And so we're taking a little bit less distal femur. I think you have to see, so understanding where to put the joint line is very critical. It's, you know, that's everything basically. So I would agree. I'm probably still on it. But I would say it's, yeah, you're probably looking at least 100 on the Mako. But before you're time negative, meaning you're saving time, yeah, I would say at about 100. I'm starting to say I would say I'm faster now with the Mako than I was with the manual knee. And I thought I was pretty fast with the manual knee.
So when manual knee, the sclerotic bone gives you a warm time with balancing the knee and throws you off. But clearly the Mako would correct nicely for that.
Most of the time. So there are some little drawbacks on it. Yeah, very sclerotic bone, the Mako's still having a problem with. And Charles, don't let Charles get going on this one. So there's still some improvements that need to be made for sure on the Mako with sclerotic bone. And hopefully we'll come up with an answer for that soon.
All right. I was going to ask about cementing. What percentage of your cases you're cementing now? Has that changed a lot or little? Or
You know, for me, it depends on the patient. If the patient looks like they have good bone and they're under the age of 65, I have no problem going cementless. Women over the age of 65, the American Joint Registry has shown increased failure rates, as has the Michigan Joint Registry, state of Michigan. So women over the age of 75, if I am going to press fit them, I have to have a really good reason to press fit them because they have a higher failure rate in the literature. But basically everyone else, if the bone quality is good, I'm going to go press fit. Because one, biologic fixation, and two, it's a little bit more efficient, you know, keeps the day moving. I'm probably press fitting about 40% of my cases and cementing about 60%. And we have an older population down here in Miami, so that's the reason for, you know, the higher rate of cement.
Yeah, probably about 60 to 70% cementless or hybrid. I'm okay with going hybrid. I think cement is a terrible thing. It's a foreign body. It's going to limit blood supply to the knee. If we can avoid using cement, the age I don't look at anymore. The one concern I have are valgus women. When you cut that sclerotic lateral bone, their medial bone is really soft. So I think the failures we've been seeing are specifically when we've seen people putting in the tibias and valgus women is my hesitation.
For your really obese patients, do you stem them or do you just go traditional?
If I can go cementless, I'm going cementless on them.
You know, the very large patient comes in two varieties, right? There's the big male whose tissues are thick and the bone is rock hard. Those get press fit.
Yeah.
There's the women, sometimes the older women who are just very soft. The fat is kind of fluffy. And you get down to the bones, you cut it and you wonder how that bone was supporting the weight of the patient. Those I'll cement and I'll use a stem on those.
Both sides? Femur and tibia?
Just on the tibia. The femur really, to me, is kind of a non-issue. Yeah, just the tibia. And it doesn't have to, I don't use anything long. I just use, you know, all the systems have like the short extension, the stubby. Yeah, I'll just use a stubby on those.
Using cement. Oh, sorry. Yes, you weren't cementing. It wasn't showing a cementing technique.
Right.
How do you modify with the robot for that uni?
So the cementing technique for me doesn't change at all using the Mako versus any other manual uni. So it's the exact same. The implants, actually, there's no cementless uni that can be used with the Mako.
What's your order of cementing?
I'll cement the tibia, and then usually I'll put a femoral trial on with a trial poly, and I'll compress, and then I'll clean out the excess cement on the tibia, and then I'll take the trials off, and then I'll cement the femur. Still one batch of cement, but I like to get that compression to squeeze out the rest of the cement around the tibia, because sometimes you get that post-op x-ray, and even though you thought you cleaned it all, you see that little fleck in the back, and you wonder if it's going to come loose and become a loose body.
A little bit. I do what Dick Scott showed us, where when I put the tibia in, I will I'll put an osteotome on the back of the tibia, push down, and try to slowly compress anteriorly to let the cement shoot forward, and that seems to work really well. And then there was a time when I was initially doing manual unis that I would put the plastic in, the final plastic, before I put the femoral component on. But as you hyperflex and that plastic's hitting the back of the femur, it would often lift the tibia up. So I definitely advise don't do that. So yeah, and I think everybody knows, I'm seeing a lot of shaking heads here. So yeah, tibia, and then secondary impactor. And then again, the Dick Scott thing was we put a little dollop of cement on the back of the femur, scrape it on, then put the femoral component on, then the final or trial liner with a tongue depressor in there, and try to keep it compressed at mid-flexion.
All right.
Yeah.
Thank you both.
Yeah.
Thanks.
Okay, so our next section is going to be on foot and ankle. We're going to start off with Carrie Chapman, who's going to talk about the evolution of minimally invasive foot surgery, a paradigm shift. And then after him, we'll have Justin Weatherall.
Hi, good morning. I'd like to thank Baptist International and Dr. Papp and Dr. Cardoso for inviting me here. I'm going to talk. Just keep on pressing. I'm going to talk about minimally invasive foot surgery. So, when making this talk, the first thing I had to figure out was, well, what is a paradigm? Paradigm is a set of accepted theories or methods and standards that define legitimate work within a scientific discipline like medicine or orthopedics. And in general, the scientist or the surgeon or the physician operate within these paradigms during periods of what's called normal science. And they solve questions that way and expand knowledge on that existing framework. Thomas Kuhn, who's a philosopher at Harvard, argued that scientific advancement doesn't really occur through the gradual accumulation of knowledge, but rather through a series of these revolutionary changes or paradigm shifts, as you've seen with total joints, revolutionary changes within what's considered dogma within a field. So what is minimally invasive foot surgery? It could mean a lot of different things to a lot of different people. Some people might think it's the same surgery, but you're doing through a small incision. But in general, it's performing a surgery through these smaller incisions or percutaneous incisions without direct visualization of what you're really working on. And typically that's performed with motorized burrs you see there in the middle under fluoroscopy. And behind that motorized burr, there's a power box that allows you to have high torque but low speed of the burr so you don't burn the bone. So the goals of MIS surgery are to have the same or better results as traditional open surgery: less risks, less pain, faster recovery, less scars. And in terms of what are we doing today in foot surgery, well, these are the basics: bunions, kylectomies, calcaneal, medial-lateral calcaneal slide osteotomies, hammer toes, or metatarsal osteotomies. And if you're talking about the history of MIS surgery in the foot, you have to go to the bunion. This first generation was started in sometime in the 80s, maybe the late 70s, and it was developed by a podiatrist in America named Stephen Isham. And he modified this osteotomy from France called a Reverdin, and they did not use any internal fixation. So this is all held together with literally strappings and tape. And this was the results were very difficult. He kind of brought this technique to Europe, and the Spanish and the Italians brought it to the next level. And this is the second generation technique where they use K-wire, temporary K-wire fixation, and they pulled the K-wires at some point during recovery. Once again, results very difficult to reproduce. There was AVN, pin track infections, and malunions. And finally, third generation, which was advanced in France and Europe, and they used the same percutaneous cutting of the bone, but combined it with AO technique with rigid internal fixation. So now we're on the fourth generation, late 2010s. Rather than doing a chevron, your typical chevron osteotomy for the first metatarsal, they use this transverse first metatarsal osteotomy. This osteotomy is an unstable osteotomy, but it does provide several advantages, mainly better screw fixation in the distal fragment, your ability to control the rotation of the head, and because you're not performing the chevron, on the picture at the bottom, when you put your screws across there, you reduce the risk of lateral blowout of the first metatarsal. So, you know, why are we doing MIS surgery? Well, there is some cosmetic appeal to it. So the picture on the right is a typical open Lapidus procedure, and the picture on the left is a patient who had MIS surgery. So people say they don't care, but they care. It's also, you know, respects biology. There's less soft tissue stripping, less disruption of the bones, of the blood supply, and you know, it's hard to explain a patient on the top right, you know, why their foot is purple and has this huge incision on it and a Band-Aid after 7 weeks. Luckily, that's not my patient. So there's also less wound complications. Like these are typical, you know, as you know, the skin on the foot is very thin. There's no soft tissue envelope. So when you have something like this, it's a problem. So there are studies showing there's faster recovery. There's studies showing there's less short-term pain. People use a lot less narcotics with this. They return to work faster. And there's actually a study that shows it improves your mental health. So if you, instead of going to the psychiatrist, you can come see your foot and ankle surgeon to take care of your problems. These are just a bunch of studies that came out in the last 5 to 10 years showing that this is a very viable technique. And this is one of the few long-term studies for any type of bunion surgery. And these are patients that had 5 years of follow-up. There was a vast improvement in the radiographic measures in terms of the intermetatarsal angle and the hallux valgus angle, and the recurrence rate. This is where I find it's made a huge difference in my practice. The recurrence rate is just less than traditional open surgery. I can't give you a good reason why, but I've definitely seen it in my practice. Additionally, the patients have improved patient-reported outcome measures. And these are just a few studies, some of the few studies that are out there about traditional open surgery. And you can see, you know, 10-year follow-up, patients have a 30% recurrence rate. And one of these studies show that there's up to 70% recurrence on bunions. So where are we going now with MIS surgery? So I can break it down to a few procedures. We're doing fusions, the forefoot, midfoot, and hindfoot. We're combining minimally invasive techniques with traditional open surgery. We're doing minimally invasive surgery, cutting bone for soft tissue problems. And we're also using it for our Charcot arthropathy reconstructive procedures. So this is just a patient who we're going to do a Lapidus procedure on. So it's a different type of surgery, basically a fusion of the first MTP joint. And we've developed some jigs to help us with that. These are just some immediate post-op pictures, and here the patient is a year later and happy. This is a case of combining open surgery with minimally invasive surgery. This is a patient with lateral ankle instability, but she has a varus heel, so we all know that varus is the enemy in orthopedic surgery. We know that there is a high, when someone has a varus, a cavovarus foot, there's a high incidence of recurrence after any type of foot surgery. So typically we would address that heel, either a Dwyer osteotomy or a lateral calcaneal osteotomy, a shift to laterally, and there would be your skin bridges, but you can avoid that now. Through a percutaneous incision, you can cut the heel. You can still do your open procedure for the lateral ligament reconstruction or your peroneal tendon tear. And rather than having these tenuous skin bridges on the left, you'll see that, I don't even know if you can see the incision there, but If I had a pointer, I'd point to the actual incision on the right where the osteotomy was done. So this is a situation where you can use MIS surgery to take care of a soft tissue problem, that being distal Achilles or insertional Achilles tendinosis and a Haglund's deformity. This is actually an old procedure developed in the late 1930s. And rather than debriding the tendon, taking it off the bone, cutting the bone, reattaching the tendon, and closing the skin, you can actually take a dorsal closing wedge osteotomy. So you take a piece of the dorsal part of the calcaneus, you close it down, you redirect the pull of the Achilles tendon, and it helps patients. So rather than risking something like this, these are uncommon, but it can happen. If it happens, it's a big deal. Also, the picture on the right is a patient who had a previous calcaneal surgery. The incision is essentially transverse, and it would go against your standard Achilles incision. It might cause a problem. So this is a patient, distal Achilles tendinosis. I make the apex of the osteotomy, which is plantar, and you see the osteotomy there. We'll use a percutaneous incision and a 3mm burr. And the little video on the left is we'll hyperdorsiflex the ankle, and that closes down the osteotomy. We'll put these through, once again, your incision. I can't point to it, but it's a very small incision on the lateral aspect of the heel, and we're not touching the patient's Achilles tendon. Some of these patients have a spur in the calcaneus, and I'm not touching that spur, and we're just leaving it as it is, and it makes them happy. And there's a recent study that came out with over 100 cases of this, and the patients have done well. Here's another scenario where I think MIS surgery has been very, very helpful. This is a patient with a midfoot Charcot. She has pain, rocker bottom foot deformity. We'll do our osteotomies through very small incisions, basically closing down the deformity, fixing the rocker bottom issue. These are the immediate post-op incisions. You can see the soft tissue prominence on the plantar aspect of the foot from her rocker bottom deformity. This is immediate, well, maybe 2 weeks follow-up. This is the patient at 6 months. So you can see the bottom of the foot is flat, no skin issues. Oh, sure. So in summary, minimally invasive foot surgery has, it's relatively new. It's like a lot of things in orthopedics. This is something that started years ago, kind of fell out of favor. And then the idea was recycled, but with a twist to make it more reproducible and more advantageous for the patient. So there's definitely less scarring, there's less pain, less opioid consumption, less wound complications. You can use it with other open techniques. I do total ankles now, so obviously that's done open, but a lot of times these patients have bony deformities that rather than staging a procedure or doing 2 surgeries to fix one problem, you can now do your ankle first, and if there's a heel positional issue or first metatarsal needs to be osteomized, you can do these through percutaneous incisions and do it all at one time. And once again, I think we're past the fad stage, and this is the future. Thank you.
So next up is Justin Weatherall, who's going to be talking about total ankle replacement. And he has a question. Have we finally figured it out?
All right, thanks for having me. It's a pleasure to be here. So I'm just going to talk about total ankle replacements. I did my residency from 2006 to 2011, and this was something that was not considered the gold standard by far. I remember my attendings telling me that gold standard was ankle fusion and that these had a really high Failure rate, I did a rotation with Roy Sanders as a fourth-year resident. He did a lot of agilities, and he was dealing with a lot of the disasters of those agilities when I was there rotating with him. And it's just amazing that from there to today, I was just listening to a podcast on the way down here, listening to a couple of people on the AOFAS talk about how they almost never do ankle fusion now, and it's almost 100% ankle replacement. So just in the last 10 to 15 years, how things have really shifted. I don't have any pertinent disclosures related to this talk. So, where did we start? So we had the agility. It's what we consider the second generation. Kind of skipped over the first generation because they really weren't that successful. This is probably the first total ankle implant that really got a lot of wide use. It required an additional fusion there. So there was more than just putting the ankle in. You had to get the tibia and fibula stabilized. Really what the study shows, it could only handle some minimal deformity, and had a very high reoperation rate. So just at 8 years, almost 2/3 or over 2/3 of these patients had to have another surgery, and 40% of those were happening in the first year. So, definitely not an acceptable rate. I mean, some of these patients may not even been starting to weight bear till 6 or 8 weeks after, and here you are letting them walk on it for a few months and then telling them, uh-oh, we might need to go back in there. Interestingly, Dr. Rakin, maybe he had got pretty slick with this or had good indications, but he even reported the highest I saw was 80% at 9 years. But I think for most people, they had very different outcomes with these. So the Salto Talaris, it's a third generation, three component, fixed bearing. It also had about a 25% reoperation rate at about 5 years. With an estimated survivorship of about 84% at 10 years. And if you had this kind of data with total hips and knees, they would find that completely unacceptable. And the issue with the ankle is when these things start to go bad, they go very bad. There's not a lot of bone stock there in the talus, so it makes reconstruction options very difficult. Additionally, we don't even have a revision component until just recently that could be relied upon. So when you look at some of these studies, they had below-knee amputation rates of several percent, which when you're talking to the patient in the clinic about, well, if things don't go right, there's not an insignificant chance you might wind up with an amputation. That really scares them tremendously. One of my mentors at Ortho Carolina, he used to have this line that he would say that would always raise a lot of eyebrows, but he would say, well, the good thing about foot and ankle is the worst complication we have winds up with a below-knee amputation, which, patients do pretty well with. And patients don't like to hear that. So then we moved on. We had the Integra, which was done in Europe, done a lot of cases there. And then in the U.S., kind of I think what really started to, change things was when the end bone came out. So we had the first generation of the end bone on the right. You can see that little jig that you had to put the leg in, very cumbersome. And that in and of itself added a lot of time to the surgery, depended 100% on external alignment guides to try to get everything corrected. So now we're on to the fourth generation of total ankle replacements, and this is where things have really moved along. This is kind of, since this fourth generation has come out, that's when what really swung the pendulum. And so Stryker, which is like the market leader for total ankles here in the U.S., I think they have about 71% of the market share. They have their kind of more minimally, bone-sparing implant on the left. They've done a modification to that original in-bone one where they made the talar component have a saddle, which added some stability to it with the implant itself. And then now they have a revision system to help us deal with some of the issues with these, such as bone loss. There's a few other companies that have come out on the market with ankle replacements. The Zimmer probably has the longest follow-up. The issue with the Zimmer is it's done through a lateral approach. So you have to cut the fibula, move the fibula out of the way. So that adds one more potential layer of complication of the procedure that total ankle replacement might go great, but then they have a fibular osteotomy that may or may not heal. And then also it's all done through the side. So a little bit of question of how much balancing you can do in the coronal plane. And then the Vantage, recently there was a recall. That was the one I was showing before that from Exactech. They had a big recall because they had an issue with their the polyethylene component and how it was packaged. And then the STAR implant, which has been around for a long time, also had some issues with loosening on the tibia. It was a 3-component design where the actual polyethylene is not even attached to the tibia component and it's free to move. And that little extra degree of freedom, I think we've come to find out, may not be best for long-term survivorship. And then the Paragon ankle now is on the market. It has very limited follow-ups. I'm not going to spend much time discussing it. So just to kind of go back to the STAR, because when I was in residency, this is kind of the one that a lot of my attendings were starting to do. It kind of, I think, initially piqued some of our excitement that we might have finally cracked the code with these. So the STAR 2 was initially a 2-component, then they added the third with the hydroxyapatite coating for non-cemented use. And Dr. Mann out of San Francisco, he showed a 73% survival rate at 15 years. The UK data showed 76% survival rate at 15.8 years, and that most of these failures were happening in the first year. And when some of this data started to come out, people were really initially excited about this implant. But some of the longer-term data has shown that the survivorship, probably isn't as acceptable as we would like. So as I talked about with the Zimmer, it requires that fibular osteotomy. It had about a 92% survivorship after about 2 years and about a 24% reoperation rate. And that was fibular hardware removal or medial gutter debridement, which makes sense because you don't really have access to the medial gutter, putting it in from the outside, and then you're adding in that extra complication of having to cut the fibula. And so with the Vantage, this one has only a couple of years. It's only been on the market since 2016, so all the recent studies only have about 3-year follow-up. It's showing about a 6% implant failure rate, and then about 20% of the implants, just at about 3 years, are showing some lucency and subsidence, most commonly on the tibia component. Recently, I had a patient come into my clinic that had one of these put in a couple of years ago, and the polyethylene had come dislodged from the tibia because the locking mechanism had failed. And so I'm going to go back to the Stryker. This is the one that I used. It's the one I trained on at Ortho Carolina. I think it's got the best long-term follow-up data, and for me, is very reproducible. So you can kind of see where it started from on the left. We had this big bulky device we had to put their patients in, but now they've developed this prophecy system that's completely eliminated that. It shaved off about 30 minutes of the surgery because you send the patient for a CT scan ahead of time, tells you exactly what kind of size they're going to be in almost all cases, can address any kind of bone loss or bone voids or deformity. So it's taken a tremendous amount of the guesswork out of these. And they've even developed the lower profile implant. And then you have great fixation options in the tibia by being able to put in the stemmed component. And then also the revision option, which kind of piggybacks off of these other systems to make it even easier to swap certain components out and still keep other components in place. And essentially what it does is when you send them for the CT scan, they generate this report. They generate a 3D printed model of the ankle, and that 3D printed model mates with the cutting guide. So when you go in there in the surgery, you set that model right on the patient's tibia after you stripped off all the soft tissues, and it just keys right into place. It uses their bone spurs that they had before to fit exactly on there. So your cutting guide is going to match what's templated on the plan. So it takes away that external alignment guide and all the guessing that might have gone in there with the parallax of the fluoro and everything. So to me, that's been a really slick advancement that's happened in my career. And so this is the prophecy system. Just a picture on the left side tells you this is kind of what the plan looks like. It shows you exactly where the guide's going to sit. You can work with the engineers if there's subtle things that you want to change. That guide matches up to the bone, pins on there, and you can do all the cuts through that guide. You can even couple the tibia and tailor cuts at the same time with the ankle. So if they have really no deformity when you put their foot into neutral position, you can do all the bone cuts at once, which dramatically shaves off the time of these surgeries. So the Stryker InBone 2 currently has our longest follow-up data. And I would say this data is very exciting. One of the reasons that there's been this massive paradigm shift from when we used to do all fusions to now we do almost all replacements. A gentleman on the podcast I was listening to this morning told me his age cutoff was 35 years and older, which to me maybe that's a little young. I don't know if I'm going down that far for my age cutoff, but just in the last 10 years, it went from we don't do this at all to now we're even thinking about doing it on younger patients because we think this is going to last. So recent 2022 study, average follow-up of 5 years, they had 98% survivorship at 5 years, 8% reoperation rate, approximately 15% with peri-implant bone cysts. So much better data than what some of the other implants that are out on the market, and a lot longer follow-up. So they came out with the Infinity, which saves several millimeters of bone. I think one of the advantages to it is it retains a lot of talus bone, because when these things fail on the talus, that's when it's a major problem because you can lose a lot of bone stock in a hurry. So recent 2 to 5 year follow-up, almost 500 implants, 2-year survivorship of 99%, non-revision reoperation rate of 3%. And then what some of the studies are showing is when these things fail, most of the failure is going to happen at 2 years. So I like to tell my patient, if we get to 2 years and you're doing well, the studies show that you're probably going to keep this implant. Most of the failures in the beginning are going to be infection or loosening. So the total knee survivorship, one of the studies I saw was approximately 99% of 5 years. I mean, that's incredible. And then 97% at 14 years. So our goal in total ankles is to get to that number. I don't know if we ever will because the soft tissue envelope in the ankle is a little bit different. The reason why people get this is a little bit different. About 70% of ankle replacements are because of trauma, not just wear and tear arthritis, but they've had something done to their ankle before, whether it's an accident or an ankle fracture, or they have just severe chronic ankle instability. So they do have, maybe their soft tissue envelope isn't great, but that's our goal. That's what we're working towards. I think it's exciting seeing what's going on with the robotic stuff in the total knee, because I do think in the future that's going to be very applicable to the ankle. Maybe we can do these through smaller incisions, try to decrease some of our wound complication rates. As I talked about before, most of these, based on the current total ankle systems with the in-bone, that most of these failures are occurring in the first 2 years. So I think we can give our patients a lot of confidence that once they make it past that mark, that they're probably going to keep this replacement long term. And then some recent data for the in-bone too that is going to be published is showing a 10-year survivorship of 93%, which is a huge improvement over way things are in the past. One of my mentors used to, when he was a big adopter of total ankles very early, and he used to always tell us when we were fellows that an ankle fusion, it's a good operation, gets people out of pain, but an ankle replacement can be a great operation because it can get people out of pain and it can restore some motion, hopefully salvage, prevent them getting adjacent joint arthritis in the subtalar joint or the transverse tarsal joint that might have them back in your office in 10 years because they're dealing with symptomatic arthritis in those joints. And once you fuse the ankle and you start fusing some adjacent joints, it just gets stiffer. And that most patients, if you end up fusing the ankle and the subtalar and the transverse tarsal joint, so you get them the, tibiotalo-calcaneal arthrodesis, we used to call that the kiss of death, that the functional outcome of below knee amputation is better than someone that has a pan-talar fusion. So nowadays, I would say in the US, you go to the American Foot and Ankle Society, everybody's talking about ankle replacement. Now for us, ankle replacement is considered the gold standard. So very important contraindications because, when these go wrong, there's a chance you could wind up with an amputation. And so these are the ones you really got to be careful of. You really want to look out for. So uncontrolled diabetes, there's, tons of stuff in the literature that this patient that their sugars need to be very tightly controlled perioperatively. And if they're just not a reliable person and they're just not taking good care of themselves, probably best to wait and hold off until they can get their health status in good shape. Or maybe that's someone that just needs a brace. Blood flow, very important to pay attention to their blood flow because these wound complications are very hard to deal with. These patients get big wound breakdowns or eschars. You're looking at free flaps to try to salvage these, which can be a real big deal. Osteomyelitis, I always try to ask these patients if they're post-traumatic, were there any wound healing complications at all when you had your ankle fracture fixed or your pilon fracture fixed? Did you have to have any second surgeries? Did you ever go on antibiotics just to try to make sure that there's nothing hiding out in there that you're going to reawaken when you do this procedure? Obesity, if you compare the size of a total ankle replacement and the surface area of that to a total knee, there's just as much weight that this thing has to to hold on to with a lot less surface area than what you might see with the total knee. So something to think about when you're doing total ankles on larger patients. And neuropathy, if you just read the technique guide, it says anybody that has neuropathy, it's a contraindication for this. I think really it's the patient that doesn't feel pain. You know, they have, most of those are diabetic neuropathics, and that's definitely a contraindication. But if there are some people that have like Charcot-Marie tooth and stuff like that where they have these problems, I don't think that kind of neuropathy necessarily makes them contraindicated. I mean, a lot of them are in a lot of pain. That's why you're in the office. And if they can feel pain on their foot, I've had a lot of good success still replacing ankles in that patient population. And then Charcot, of course, contraindication, because you could just waken that thing up and then the implant's going to fail. And now you got a big problem. So something to look out for there. And if they're, kind of going back to the uncontrolled diabetes, if they have uncontrolled diabetes and you do the ankle replacement, they can get Charcot in that ankle. So that's why I think very critical to keep their sugars under very tight control. And also just what are the patient's goals? I mean, if they're telling me they want to run marathons again or do these high impact activities, they may not be a good candidate for this. We really just don't know how much activity these implants can handle. And osteoporosis, definitely, I mean, almost everybody press fits these in nowadays, even though it's technically FDA approved for cemented use only. Everybody's press fitting from just because they get the bony in growth for longevity. And so if they have really soft bone, I think that's also a big contraindication. Thank you.
Okay, I think that was a great job. We're going to move to some questions. Any questions? Yeah, go ahead.
For the ankle replacement, so is there literature comparing the patients having previous trauma and or IAF with patients having nothing? I mean, the results, the survival, the implant is the same, loosening, etc. And in these cases with this trauma, previous trauma with hardware, how do you really kind of approach the fact that they have a lower infection and that can impact the outcome in the future?
Yes. So as far as the trauma component, one thing you always look at is where are the prior incisions? Do they have any deformity from the trauma? Because that is always a challenge to deal with. If there's, the fibula was fixed in valgus or, some of the literature, I don't know if we have enough even at some of these big centers where they've totally broken down and looking at it. I mean, there was a recent study out of Duke comparing difference in ages. So they looked at the younger patients that had total ankle replacements versus the older patients. And the older patients reported better satisfaction scores. They were happier after having it done. And there's that thought of, well, why is that? Was it because the younger patients were 100% trauma, total ankle replacements? Or is it just because the younger patients have higher expectations in that particular study? And maybe if you're 75 years old and you're not that active and your ankle's been killing you for 15 years, you're just happy to have something better than what you had before versus the 35-year-old that had a bad car accident and a bad pilon fracture 2 years ago. And 2 years ago, they were great. They were running around with their friends, and now they're limping all over the place, and they may still limp or may still have a little bit of pain and swelling after having an ankle replacement. Most of these are trauma. It's just that somewhat related. 70% of them are post-traumatic in general. So I think they can do very well, but I do think that does matter is their ages. And as far as the infection issue is concerned, if everything looks good, they didn't have any complications, post-op complications, they don't say anything in their history, then I don't worry about it. The other ones that maybe they're just a little swollen, they're a little red, I mean, they're going to get a workup from me, ESR, CRP, potentially even a bone scan, just anything that I can do. And then usually when you do the prophecy anyway, there's at least a month delay with that. So you got time to, or sometimes longer because you got to get a CAT scan first. You have time to kind of work a little bit of that stuff up. Kerry does total ankles too, so he may have a little to add.
Yeah, in general, I agree with all of that. I think that if a patient has a history of an open fracture, and I'll ask them if there's bone was sticking out of their skin or anything, those patients I'm going to work up, even if everything looks great, even if they didn't have any, initial postoperative complications. So I'll do the ESR, and I depending what that shows, I might get a white cell label bone scan. Regarding the age or the trauma issue, I do think there's some literature out there showing that these patients have patients specific for trauma have lower functional outcomes and slightly higher revision rates, but that can also be a function of the fact that these patients tend to be younger. They develop their arthritis in their 40s and 50s, and they're getting their surgery at a younger age.
I don't know if it's because I have such a mundane practice or this is an interesting topic, but either way, thank you. It's very enlightening to us over here. Question, just curious about how the ankle works. We talk about joint reaction forces. The hip sees about 4 times with every step. The knee, especially in a nasty varus thrust, can see up to 6 times. Does the ankle follow those same thing, or is it's still a very high joint reaction force environment?
Yeah, I think it's about 3 to 4 times through the talus. And in addition, I think one of the reasons why these things failed in the past, the quality of the bone, the subchondral bone in the distal tibia is different than in the knee. And also when you're thinking about the talus, I mean, you could cut it 2 centimeters off or take a little bit too much off, and then next thing you know, talus is dead. It's just a different type of bone. So that's probably one of the reasons why these have had traditionally higher failure rates.
Yeah, I know me personally, I like the chamfered talus. That doesn't seem, there's a lot of people in the foot and ankle world that still do the flat cut talus, but I just try to preserve as much of that bone as possible and give as much surface area of contact for the implant just to try to prevent problems on the talar side. Because when it fails on the talar side and that thing just collapses into the bone, now you got a big bone defect to deal with, which can lead to 2-stage revisions and maybe even a year of time trying to get that patient reconstructed.
Thanks for the great talks, guys. I'm very unfamiliar with total ankle replacements. This is fascinating for us arthroplasty.
We're trying to hide it from the total joint guys. We don't want you guys doing it. We worry it's getting too easy.
How do you counsel your patients on what things are going to look like post-operatively? The total knees, we tell them you may have residual symptoms. The total hips, we tell them you're going to forget about it. Like, where does the total ankle kind of stack up on that spectrum of residual symptoms and how they're actually going to function?
So the 2 biggest things that I see is persistent swelling. And it's not in everybody. I have a lot of ankle replacements. I look at their ankle and they're just like thrilled. It doesn't swell anymore. It looks great. They're happy. And then I have those that are seeing me a year out and it still swells and they still have a little bit of pain. The ankle replacement that I use, it doesn't resurface the gutters. So I try to do a good job getting on each side of the ankle to try to get some of that stuff out. But maybe I miss one in the back or something like that, or there's just a little impingement there in the fibular gutter or the medial mal that I think does cause pain, especially when they're walking and the ankles being fully dorsiflexed. But if they're having 7 to 10 out of 10 pain and I get them to a 1 to 2 out of 10 pain, usually pretty happy with that.
Yeah, I tell patients like between a total ankle and a fusion. I mean, I think the studies have shown that the pain relief is equivalent. It's just that total ankles tend to have this issue of needing some type of maintenance procedure. So granted, we've gotten the failure rate or the revision rate down, but there's still more patients than I'd like to see have some other type of issue like gutter impingement. You're developing osteophytes and that causes pain. And you still have to go in and do something for that. Whereas a total ankle, an ankle fusion, once it's healed, I mean, you really don't have to worry too much afterwards. Granted, some patients will develop subtalar arthritis or talonavicular arthritis, but most patients don't need that next surgery. They don't need a pantalar fusion. They just kind of live with what they have.
I think one thing's nice is the MIS system. The couple that I had to take back for gutter debridement, since that's come out, I do all those MIS. So it's just a little poke hole. So it's really minimal downtime for the patient.
You're not afraid of that burr. messing up the ankle, the
No.
poly.
That's usually distal in the gutter, down near the bottom, away from that stuff.
Yeah, in the cases that you need to do a revision of a primary arthroplasty, do you think about going back like to a fusion or versus using revision implants?
Well, I think bone stock is important, and then just a conversation with the patient. I mean, some of them, they really want to keep their ankle motion. So the revision is a little, for them, that's more appealing to them. Because the fusion is a TTC. So if they have, if their subtalar joint's still working pretty well, it's going to be a much stiffer ankle than what they had before. I trained with a bunch of guys that did a lot of total ankle replacement, so maybe I'm a little biased to that. That we weren't doing a lot of big TTCs. We were trying to revise these and fix these in fellowship. So I've been trying to do the same thing with my patients.
May I? So we get a lot of complicated cases that get referred from abroad. And question I have for you is, on these complicated cases, for us to be able to refer towards you, what are you looking for as far as in imaging? What's the best thing? How could the physicians abroad help you best to set up a patient for it to be seen for a second opinion or something like that?
Standing x-rays, that's always key for us. Standing x-rays and just their history, like infection or, diabetes, those types of things.
Yeah, I think a clear history would be good, because it's hard for a layperson to understand, whatever issue they had before. Why did things fail? I don't think we need to worry about CT scans, because we probably want to do them here, because there's a specialized CT if we're going to do some type of reconstructive procedure. And even the X-rays, if it's a non-standing X-ray, it's really not very helpful. So a lot of the stuff, honestly, just get the patients over. We'll take care of the workup.
More mundane question. With regards to the bunion surgery, I saw you did osteotomies of the proximal phalanx for bunion correction, for hallux valgus. But those hallux looked normal. So what is your threshold for doing your?
You mean adding like an achinosteotomy to the?
Yes.
Yeah,
the ones you showed.
I would say that for a standard minimally invasive bunion, where we're cutting the first metatarsal neck and the proximal phalanx, 99.9% of the time, I'm going to I'm going to do the achinosteotomy, because people like their toes straight. I mean, there's sometimes these things creep back just a little bit, so we never really cut them into varus or anything like that. It's cut and the toe is straight. Sometimes the thing will creep back into valgus, and if I don't want to say overcorrected, but if you've made that correction, you don't have to worry about it. But I would say that 99.9% of the time I'm doing aching.
Yeah, same for me.
So I'll ask a quick question. I saw what looked like a mid-foot fusion nail with your MIS talk. That didn't exist. Is that something that's off-label use, or is it helpful?
No.
Like not like.
Well,
I'm
it
dealing with
is
circumference.
specific for like a medial column fusion, so it's not for the ankle. It is a specific nitinol product, so it actually has some internal compression once you get the thing in there. But it's so in the old days, we'd do this huge whack along the medial column and put a huge plate on there or two, and a million screws.
That's
there
my generation.
Well, that's my generation. That's my generation too.
It's still going on. I would
Yeah,
say
it's still going on. But obviously, you have intramedullary fixation is better than using plates, and now you see that you don't have to make that huge whack to do your osteotomy to realign the foot. So it's not that new, but it's relatively new.
I think it's great. Were there any other toys that you use that are different than was used, 15 years ago?
I'm sorry, say that
Are there
again.
different like implants such as like that?
I don't know. What do you think?
I mean, I would say I finished my fellowship in 2012, and it's remarkable how many of my surgeries are done differently today than it was in my fellowship. I mean, bunions, we did a lot of opening wedge, course distal chevron, some lapidus. zero MIS, and now everything's shifting towards MIS. We couldn't fix no one knew how to deal with metatarsus adductus in a bunion, and now I think we're coming up with some solutions that are all MIS, which are super exciting, because I really used to just tell those patients, keep your IMA angle is normal. I know you got a terrible bunion, your toes are windswept. I don't know if I got a surgery other than a hallux MTP fusion to fix you. And now with MIS, that's to me really exciting. The only thing I feel like I've seen with MIS, maybe it's just me, but they do tend to swell a lot, because sometimes some of these bone cuts are not internally fixed with screws. Maybe you're strapping the toes or holding them down, and it takes longer for those bones to unite, because they're not compressed together like AO technique. They're floating a little bit, so you're depending on secondary bone healing. So that's been the only little thing that I've seen is patients will swell a little bit longer than I used to do an open distal chevron.
Yeah, I agree. I finished my fellowship in 2004, and I don't do anything like I did back then.
No, thank you very much. I think this concludes our foot and ankle session. We're going to move on to a break. So go get some coffee, and yeah, we'll see you later.
The screen and I think the weed in between everything I've seen in my dreams. Everyone's so weak, I'm on my feet, can't sleep. Have you underneath all of my beliefs? Give it breathe. I wait in the sweet, keep me off my feet. You seem so paranoid. I'm looking at the boys. I've never felt the void. Out of spite, you seem so paralyzed. It's so romanticized. If this is how I die, that's alright. I've been overseas. Don't need to breathe when you look at me. All I see is green, and I sing that we're in between. Everything I've seen in my dreams, I don't want to leave. Feeling on my feet, can't sleep. Have you underneath all of my beliefs? Keep it brief. I see you in the street. We can be discreet. But I've been overseas, and I've been having dreams. I'm over my league. That's so bittersweet. Open up the door for me, for me. 'Cause I'm still on my knees. I'm staying off my feet. I've been overseas. Don't need to breathe when you look at me. All I see is green, and I sing that we're in between. Everything I've seen in my dreams, I've been wanting to leave. Feeling on my feet, can't sleep. Have you underneath all of my beliefs? Keep it brief. See you in the street. We can be discreet. your time, walking slowly, take your time with me. Close your eyes, breathing deeply, tell me what you see. Every moment feels like golden hour. Did you know that you're my superpower? My heart's beating and it's growing louder. I'm alright, 'cause I'm here with you. I'm here with you. Walking slowly, build an dream. What I found feels like falling, you're my melody. Every moment feels like golden hour. Did you know that you're my superpower? My heart's beating and it's growing louder. I'm alright, 'cause I'm here with you. I'm here with you. The creator, the distance between us now is greater. Calling the believers, no gathering flocks and tribes and legions. 'Cause we are the lovers, we're protectors, defenders, and healers. 'Cause we are the lovers. While we waste time, we are the lovers, we're protectors, defenders, and healers. We are lovers, we're believers, and the deceivers. Everything about you, every single detail, just wanna know. Everything about you, every single detail, just wanna know. Every single detail, everything about you, just need to know. 'Cause we are the lovers, we're protectors, defenders, and healers. 'Cause we are the lovers, we're believers and the keepers. Every single detail, just wanna know. Everything about you, every single detail, just wanna know. We're protectors, defenders, and healers. We're believers and every day. I'm here for you every day. I'm here for you. Standing on the edge, you were almost the lover who we messed up. Never thought it could happen so fast. Yeah, I've been biting, now I'm broken. You were almost the lover to love, a lover to love.
Okay, we'd like to ask people to start moving towards their seats so we can keep going. I had an old chairman once upon a time said trying to get orthopedic surgeons to do some things like herding cats, so sit. Next session is going to be hand and upper extremity. I do want to thank again Baptist Health International for putting this together. I think it was a really great opportunity for people to get together and talk. So again, thanks to the international department, thanks to Roger, everybody, you know, Nicola, Raul. So first up is going to be Roy Cardoso. He's going to talk about forearm fractures. I am honored to have him as my co-conspirator on this meeting. So.
So this morning was filled with really innovative talks from the foot and ankle and the joints guys talking about robots and MIS and all that other sexy stuff. So it's time to recalibrate our expectations, and we're going to talk about something a lot more mundane, but I think important. You know, when we talk about forearm fractures, I think back to, you know, as a resident, these were some of the first cases I was involved in, right? So pretty straightforward. You plate some bones, you go home, and you feel good like an orthopedic surgeon. But I think there's some subtlety to forearm fractures that makes them interesting. So hopefully I can highlight some of that. So here's a case, fairly standard. This is like a Monteja type fracture. You see here, and this is kindly shared by one of my trauma colleagues in town who's a very good surgeon. And so they plated it like this. Does anyone see any like particular problems with this? It looks like the bones are pretty lined up. It looks like the fracture is reasonably reduced. But this is what happens. You get a dislocation of the radial head, and we'll talk about why there's a problem with how that fracture was fixed. So, you know, what's interesting about forearm anatomy is really the relationship between the osseous anatomy and the ligamentous structures. As hand surgeons, unlike our trauma colleagues or our joint colleagues, we like to mess around with the things in between the bones, those soft, mushy parts. And that's what makes forearm fractures and forearm anatomy interesting. And so the forearm helps to maximize rotation and power while maintaining stability proximally and distally at the elbow and the wrist. So the way the forearm can do this partly is because of the shape of the bones. We all know about the radial bow, but actually the ulnar bow is equally as important. And then we have these ligaments, the interosseous ligament, the TFCC, that help to tether these two bones together. So again, they're long bones, but they're not straight bones. And we all know about the bow of the radius. What is, I think, underappreciated are the various bows of the ulna. The ulna has the the proximal ulnar dorsal angle, which is critical. And the reason that fracture failed was a little bit of failure to recognize that you're putting straight plate on a curved bone, and so it was not reduced anatomically. And so there have been various iterations of ulnar plates, but what's critical is that you have fixation or recognition of the anatomy or fixation that matches that. We're going to also talk about the forearm as a joint. So if you think about the forearm as having two fixed lengths, the radius and the ulna that are fixed, you have the joints both proximally and distally. You have this sort of parallelogram is the effect, and they rotate as one functional unit. So it's really a joint, not two bones. And the radius, as we all know, rotates on this fixed ulna. And so talking about these, taking a deeper look at the ligaments between these two bones. So you have this central band, and then you have a proximal oblique cord and a distal oblique cord that help to fix this. And what's interesting about the interosseous ligament is that both in the anterior and posterior views, and in pronation and supination, it's an isometric ligament. So you see here that, and this angle has been, this is a 21-degree angle, but you see that there's an isometric ligament in all ranges of motion. So taking a closer look again, you know, it's the purpose of the ligament is to load transfer. So we have the forearm transmitting load, and the ligament helps to distribute that load evenly between the proximal radius and the proximal ulna. You have this balance that's created. So this 100% load gets evenly distributed between the two bones. And so when we do have an injury, so you have a radial head fracture, and you have an injury to the interosseous, like in an Essex-Lopresti lesion, you have this migration, and you have this disruption of the load. And so now the load of the interosseous ligament is greater than the axial load, and you have failure. You get this migration that we all know about. Interestingly, restoring the length, the ligaments prevent, these proximal and distal ligaments prevent over-lengthening of the radius, which is a benefit. And so we're thinking more about the ligament and the relationship of these two bones, the soft tissues, rather than just thinking about the bones themselves. This is true for ulnar impaction syndrome, a bunch of other things where we always focus on the bone, shortening the bone, when maybe the problem is not the bone, but it's in fact the ligament and ligament tension. I'm going to switch gears briefly to Galeazzi fractures. You all basically know what this is. It's an injury to the distal radial ulnar joint along with a distal radial 1/3 fracture, the counterpoint of the Montesia fracture. And it was first actually described by Sir Astley Cooper. He described this in 1822, but it wasn't until 1934 that the eponym Galeazzi was presented. And Riccardo Galeazzi, he's actually not the most famous Galeazzi. There's another Galeazzi who was actually he was the doctor for the Pope, and he left the Vatican disgrace because he was responsible for the embalming of Pope Pius. And so the typical embalming method is to drain blood from the body, et cetera, and he decided that he has a new way, and he wanted to innovate that with the Pope, and it involved keeping it at room temperature, not draining the body. And he filled this plastic bag with these herbs and spices. He's like the Colonel Sanders of embalming, apparently. And the body apparently decayed in front of everybody. It rotted, essentially. And apparently there were these Swiss guards that fainted from the stench, and it was a big mess. So if you look up Galeazzi, that he is the most famous Galeazzi. So this Dr. Galeazzi is from Milan, and he published on his experience with these 18 fractures and described the mechanism, incidence, and management of these Galeazzi fractures. And its more defined treatment was described by Houston later. Mechanism, it's a fallen and outstretched hand. The rotation of the limb as it interacts with the ground or whatever object determines the mechanism of the injury. There are 7% of all forearm fractures. A fourth radial shaft fracture is a true Galeazzi fracture. There's a bimodal distribution. As many things in upper extremity trauma, there's high energy trauma versus low energy falls. Reddick and Raskin basically described two types based on how far the fracture is from the distal radial ulnar joint, and the magic number is 7.5 centimeters. So if it is closer to the distal radial ulnar joint, understandably, it's associated with significantly more instability than if it's more than 7.5 centimeters. Other concerns, anterior interosseous nerve palsies. And then the other most interesting thing about these Galeazzi fractures is, what do you do with a distal radial ulnar joint? So are you splinting them? Are you pinning them? Are you exploring them? How do you decide? And so there's so many algorithms out there, but basically if you can reduce them and they're stable, then you splint them in supination for 6 weeks. If they're unstable, you have the option of pinning them or looking to repair the TFCC. So reduction in pin versus screws versus opening the TFCC and actually fixing it. And so this is a very busy slide, but essentially going through that protocol, and if it's reduced and stable, you leave it alone. If it's unstable but reducible, then you have to decide if you're going to pin the two bones together or if you're going to go in and repair the TFCC. And obviously, if it's irreducible, you have to explore the ligament and then decide to either fix it or pin it. So that's basically it. The forearm is placed in supination. You have to watch out for compartment syndrome and anterior interosseous nerve palsy. I take the pins out at about 6 weeks, and then we recheck for alignment. So that is it. Thank you very much.
Thanks again to Dr. Roy Cardoso. Before we get our next speaker up, I do want to, again, thank the international department. Apparently we have 24 people logged in internationally, so that's really neat. It's a success. So it's great. Our next speaker is Dr. Rafael Diaz-Garcia, who's going to be talking about basically nerve and tendon transfers. So welcome.
And thank you all. And as we've been talking all about the joint replacements, I had a little bit of jealousy that we don't have any robots yet for anything that I do. But I joined Baptist about a year ago, and like most things Roy was talking about, we take care a little bit about everything, but I have a personal interest and passion for nerve injuries. So, nerve is something that I think we all interact with. A lot of us are scared of. We try to make these planes between the radius and the vessels and the nerves, and try and do whatever we can to get down to the bone without ever seeing the nerve, because we're worried what might happen if we injure it. Because ultimately, when there's an injury, the recovery is never 100%. So I'm hoping to really just do a brief overview. Any one of these topics, we could literally spend an hour, but discuss peripheral nerve injuries and the evaluation in them, what the algorithm is with chronic injuries, on what to choose, and ultimately show some cases that I've done in the last year here to talk about kind of my decision making and why. So, nerve injuries are mostly common in working age populations. So these are young laborers, whether it be in motorcycle accidents, whether it be industrial accidents. Most of these people need to get back to work and have numerous years of productivity in them. And because this is such a hardworking population in general, the socioeconomic costs of an injury is significant. In a perfect world, if you have a laceration, a clear laceration or injury, getting to it early and repairing it primarily is still the standard of care and really the best option for recovery, depending on the location. But sometimes, based on either the history of the patient or the nature of the injury, you can't get primary repair. And so deciding whether or not you're going to do something for the gap, whether it be grafting or allografting, or some type of nerve transfer, or do they present in a later fashion, then limiting the options you have. All of us during our med school and early training days talked about nerve injuries and Wallerian degeneration. Ultimately, the idea that when you injure a nerve, in the first 3 days, you start seeing loss of the axons downstream, and you have this influx in the first week of macrophages that come in and essentially take away everything except for the microtubules, and you need to get new growth from the proximal cell body to go down to the terminal end plates. For closed injuries, really timing dictates what you're going to do at that time. So when do they present to you? Do they present at the time of injury? I really just want to get a good exam if it happened the day of so that I can follow it. Does it get worse? Does it get better? And then really following those patients closely, usually at 6 to 8 week intervals, getting a good understanding of which muscles innervate in order so that I can keep track of their reinnervation. And if they either don't progress as I expect them to, or stop altogether, then getting nerve conduction studies to see, are they progressing? Do I have evidence electrophysiologically of reinnervation? And if not, then really talking about intervention. And that surgical intervention, at least in terms of some type of nerve, recovery directly to the nerve transfer, nerve grafting, is usually going to be somewhere in the 3 to 9 month range. So somebody who's a year and a half out from injury, I'm not even really thinking about their nerve unless they're talking about pain. I'm thinking about tendon transfers and trying to reconstruct their overall ability. But if you get them early enough, then you can start discussing whether or not nerve transfers, nerve grafts make sense and can potentially give them a better outcome. Nerve injuries are, mostly from mechanical trauma, but I've seen them from toxins, I've seen them from burns, I've seen them from external beam radiation for metastases treated in the humerus, as one of the patients I'll show. And obviously the type of injury is important to have in the history because it gives you an idea of the zone of injury you're dealing with and whether or not that is a hostile bed to try and operate in. So somebody who has a sharp laceration, then they have minimal soft tissue injury, you're more likely to be able to do something locally. Somebody who has a gunshot wound or had a bad burn that it's multiple segments of that extremity, well then I really want to avoid that altogether unless I'm going to do some type of soft tissue reconstruction as well. And thinking more of things like distal nerve transfers. So, tendon transfers, the idea of a tendon transfer is that you are taking a functional muscle that does a different function, has done it his whole life, and you're going to use that function to reconstruct something that they're lacking. So the key principles that go back to Dick Smith at Mass General, 40 years ago, is that you do one transfer for one tendon for one function. You want it to have a straight line of pull. If you have to make it, take a turn somewhere, you're going to lose some of that strength and you're going to lose some of the efficacy of that transfer. You need to have sufficient excursion. The same idea that you can't take your pronator quadratus and try to make that a digital extender because obviously the pronator quadratus doesn't have much excursion. And you need strength. So a weak muscle isn't going to be stronger once you do a tendon transfer. Usually you actually lose 1 BMC level when you do that transfer. So if you're using a 3 in somebody who had a multiple nerve injury extremity, you can't use that muscle to do a tendon transfer because you're going to weaken, you're no longer able to have even anti-gravity function. And you need to have an intact soft tissue envelope. So for somebody who comes in with a long-standing injury, but a lot of scarring, maybe they had skin grafting, if you don't have a good soft tissue bed to have that tendon transfer go through, you may need to stage that. You may need to do a free flap or bring some type of soft tissue to give a hospitable bed for your tendon transfer to be able to pass through later on. The best candidates are going to be patients who have chronic injuries. That's when you've kind of given up the chance of their reinnervation, and usually you use a cutoff about 18, but usually I'd like to think people may see some recovery up to 2 years, so I'll wait if I can. People who have failed nerve reconstructions before, people who have limited nerve options, and really you start thinking about combinations of arthrodeses with tendon transfers to try and improve their function. Common applications, so people with radial nerve palsies, commonly from a humerus fracture, median nerve palsies, classically from long-standing carpal tunnel, but anything that caused a median nerve injury, you may want to reconstruct their thumb opposition to put their thumb into better space. Ulnar nerve palsies, the intrinsic function, particularly with clawing, can really limit their ability to even grasp a cup. So being able to put their hand into better posture will make a difference in how they use that hand. And then for our foot and ankle colleagues, people with tibial, tibial anterior palsies from a peroneal nerve palsy can ultimately get TP transfer to stabilize the foot. The advantages are these are fairly straightforward operations. Patients recover much faster, so you may have to splint them for a few weeks, but then you get them moving with therapy. And then usually I tell patients that by 6 weeks, I don't really have any restrictions, and by 8 weeks, they should be kind of plateaued. They may still see some gains, but they're back to most functions. The problem is that it's non-physiologic. You're trying to use synergistic transfers, but oftentimes you're kind of using a B choice muscle to do an A choice function. And oftentimes you have one muscle trying to compensate for what would be normally multiple muscles. So for instance, classic, FCR transfer to EDC, it has good excursion, has good strength, but you can't individually extend those fingers because you have one muscle now that contracts and pulls them all together. And then they do have to have access to rehabilitation. So nerve transfers have really popularized over the last 20, 25 years. Susan McKinnon at WashU was kind of like the first person to start pushing it, but goes back to Christophe Oberlin in France talking about, Oberlin transfers or FCU motor transfers to get biceps flexion. And the idea there is you have a functional muscle that just is denervated, right? It's early on. You have functional nerves nearby, and by rewiring the circuits there, you can have synergistic motion, and you now don't really need to have that one line of pull, one muscle, because as long as you get about 30% of the normal axonal count to reinnervate that muscle, you actually have normal contraction. So people can get really great results in the right patient population. But you do need to have healthy nerve to try and do the nerve transfer, and you have to get to them early. So that's why I say that 6 to 9 month window is when I'm really kind of making that decision to operate on them, because if they show up a year, year and a half out, you're probably not going to be able to get reinnervation in time, and you kind of are going to waste that nerve transfer. So your best candidates are going to be those acute to subacute injuries, patients with high proximal injuries, because you know that the time to reinnervation is going to be longer than you have access to. Younger patients, they have more neuroplasticity, they're more likely to have regeneration in a timely fashion. And these are some of the common ones, so like the Oberlin transfer for elbow flexion, or the double fascicular that McKinnon has popularized, AIN to the ulnar motor to prevent clawing and give better posture to the hand. And then I mentioned the tibial to peroneal nerve branches, which is, I'll tell you, works in the sense that you can make that muscle contract, but I'll tell you it does not work for patients because it's not a very synergistic transfer, right? So toe flexion and extension of the ankle, dorsiflexion of the ankle, don't ever happen together. And so I've done them in practice in the past, in my previous job, and for your office, you can get them to extend their ankle, and it can look really good on your video, but when you actually try to get them to be able to have improved gait, it doesn't really work. Patients just don't relearn that. And so I think they do much better with tendon transfers for that particular indication. So the advantages, so you're preserving those original muscles, you're just giving them a new source of signaling. It's more physiologic, they have better fine motor control, and it's kind of, I tell patients, it's the home run, right? If you get it to work, they do so much better, but you got to pick those patients. It's time dependent, so the longer you've waited from the injury, the less likely you're going to get recovery. It's variable, so versus having over 90% success rate with tendon transfers, you're more now in the 78 to 82%, depending on which transfer you're talking about. Older patients struggle with the cortical relearning. It does require comfort with intraneural dissection, being able to coapt 9-0 sutures between fascicles, and really understanding the interfascicular anatomy of each of the nerves we're using. So this is kind of a framework of when I'm thinking about tendon transfers or nerve transfers. So a younger patient who comes in fairly early after their injury, I know that based on their nerve conduction studies that those muscles still have a lot of fasciculations, which tells me they're very viable. I haven't waited a long time, so I know I can get them reinnervated. And they want to swing for the fences and get the best option, then those are patients that could do well with nerve transfers. Patients who are older, patients who have chronic injuries, patients who may not be somebody who wants to have to do therapy for 8 months to a year. They just want to get back as quickly as possible, and they don't necessarily want to be invested into this long recovery period. They're going to do better with tendon transfers. And then again, time-based, so early injuries, acute, sharp, primary repair. Longer injuries, I'm starting thinking about nerve transfers, and chronic injuries, tendon transfers as the primary option. Young patients do better with nerve transfer outcomes than older patients. Older patients are going to be happier with the predictability of a tendon transfer. Patients who have comorbidities, so diabetes obviously we know is neurotoxic. It impacts our nerve regeneration. Same thing with vascularity. So patients who either smoke or have a history of coronary artery disease, you start thinking that maybe they're not going to be the best candidates for nerve transfers. While people who have soft tissue problems, rheumatoid, lupus, they may not do as well with tendon transfers because they may loosen over time. And so let me just go through some cases. These are patients I've taken care of here. This was a 73-year-old female that came in from the Dominican Republic. She was 3 years out from supposedly excision of a benign breast mass. And they injured, the surgeon told her that, oh, the mass was on one of the nerves, told her it was the radial nerve. Took out her medial cord. And so she waited horrible pain for over a year. She comes to see me 3 years out, and she had actually recovered function of her ulnar nerve, but still had a high median nerve palsy. On appearance, she had a hand of a benediction. She had some function of her middle finger, probably because we know that there's some cross innervation of the medial FDP from both the ulnar and the median. But she had no sensation in the median nerve distribution. And really struggled with lack of AIN, particularly with thumb flexion and index finger flexion. And so I took her ECRL, and I used that as a tendon transfer, rerouted to now give her flexion of her FDP of the index and her FPL. I did a side-to-side of her middle finger FDP to the ring to give her a little better excursion. And then because she was insensate, and sensory transfers you can really do years down the line, I took the dorsal sensory branches from those fingers and then rerouted them to the key digital nerves to give her key pinch back with protective sensation. And so here you can see the tendon transfer as well as the sensory nerve transfer. And at 3 months, you can see that now she has flexion. And I saw her at 7 months. She was now getting some protective sensation along the distribution of her ulnar thumb and radial index. This was a patient who had a history of thyroid cancer. She developed a metastasis to her humerus. She was treated with external beam radiation, and she developed a radial nerve palsy. And she comes to see me. She's 4 months out. She has no function of her radial nerve distal to the triceps, except for sensory, where she has about 50% of her contralateral side in the sensory distribution. And so I talked to her about the options. I gave her, she's young. I'd say I can give you tendon transfers. You can kind of be back to activities in a couple months, or we can swing for the fences and do a nerve transfer. So she opted for a nerve transfer. And so here you are. And again, people oftentimes try and avoid these things. I'm looking for them. Here I'm dissecting out the motor branch, the FCR, going into the muscle, trying to get as much length there. And then the FDS usually actually has two kind of bundles that go into it. So take the more proximal of the two bundles. I stimulate the nerve to make sure that there's another one, that I'm not sacrificing FDS function. And like I said before, you only need 30% of the nerve to maintain normal function. So you can take half and they don't see a deficit. And then go ahead and transfer. I dissect the superficial radial nerve back as my way to find the nerve proximally. I find the ECRB, take my FDS branch, go to ECRB to give wrist extension, and then FCR to PIN to try and give digital extension, where you can actually get independent digital extension with this transfer. I don't know how I can play this. Does anyone know? Great. So this is 5 months out. There's no tendon transfer that allows you to give them extension in one position of their wrist. They get this kind of static position where their wrist is held in neutral, and with tenodesis, they can get a little bit of motion, but to get that full flexion and extension, you can't get. And then I tell them up front, 5 to 6 months to get wrist extension, and about 8 to 10 months to get digital extension. So she's halfway there, but she knew that up front and was okay with that plan. And then case 3, this is a patient I just operated on recently. 26-year-old male, had a history of a anterior shoulder dislocation, had plexus was completely out, was left dislocated for almost 8 hours, but posterior cord was still intact. Recovered over the time I was following him, but was starting to get a little bit of AIN function back. And we talked about waiting, potentially doing tendon transfers later. Really wanted to do something to preserve. So I told him, well, there aren't great options when you have two nerves that were injured originally. I would much rather have a nerve that was completely normal. But because the AIN doesn't give you that much of a loss, people don't really miss their pronator quadratus. I offered him a distal AIN transfer. And so I released his cubital tunnel. I transposed his nerve because it was subluxing. I stimulated intraoperatively. I saw the AIN to the pronator quadratus was contracting, so I knew that it was already reinnervated. I knew that it wasn't normal, but I didn't have any other good options, and I haven't burned any bridges, so I can still do tendon transfers in the future if he doesn't get good function out of it. And thank you very much for your time.
Thank you again for those wonderful talks. I wanted to plug TCOS. If we've got 24 international people listening to this, our annual meetings at the beginning of October, and there's going to be a foot and ankle course at the end of this month. So join us. Yeah, so two great talks. Does somebody else want to start with questions? Otherwise, I can share a case. Go ahead.
A quick question on the nerve transfers. I have a patient with a gunshot wound to wrist, and we know that the superficial branch on the nerve is gone, and there's the zone effect of the gunshot wound affecting and the neuroma of the other branch on the nerve. What would you do for assessing the next move at 3 months?
And motor function's always been fine?
On the nerve? No.
So both motor and sensory are out?
Correct.
Yeah. So at 3 months, I would probably be talking to them. If it's at the wrist, I don't think there's any good options for transfers. I would talk to them about resecting the neuroma. Intraoperatively, once you do a neurolysis, you can dissect out the fascicles and try and do stimulation to see if there's any motor function that's working after neurolysis. I've been surprised by sometimes, somebody comes in with a C5-6 palsy and I explore them, I release their scalenes, and as soon as I take off all the scar from their plexus and I re-stimulate, now it's contracting. So if I see that after my neurolysis that I'm getting some contraction, then I probably would save those fascicles and then autograft what wasn't working. And a plan for essentially taking their whole sural nerve and doing multiple cable grafts.
Question for Dr. Cardoso. How important in terms of that proximal ulnar bow to get that anatomical with your mantisia fracture? Because that case that you showed, that same thing has happened to me, where I fix it and then afterwards the proximal radioulnar joint dislocated after surgery.
Yeah,
but it's something that we tend not to focus, well, at least I don't, a lot on in terms of fixing the fracture, in terms of getting back that dorsal bow.
Right. I think it's pretty important. It's pretty common. So it's not just you. I think it's pretty common to misinterpret how bent the ulna is. A lot of the newer implants incorporate the bow quite well. What becomes difficult is if you're planning a fracture out and you see the X-ray and you're like, oh well, this is a mid-shaft fracture. I can use a straight plate and that's what you have available. But inevitably you have to go more proximal than you think, and you have to take into account the bow. So I think it's quite important. What degree does it have to be like equal to the other side? A 30-degree bow, I can't tell you that there's an exact percentage that you have to be close to in order to have a stable proximal radial ulnar joint. But it definitely needs to be considered always.
Yeah, I think that Dr. Cardoso was saying, I think that the anatomic implants have made that a lot easier. I think that before, particularly because you're going from a dorsal approach and you're seeing, 2.5, 3 cortices, and you can't tell the gapping on the volar side. But with an anatomic plate, it kind of gives you another registration point, like, oh, why am I still not lined up with this plate? I shouldn't be bending this plate this much. Maybe I have to get another look and see, am I lateral? Am I actually gapping?
Um, and to that point, the surgeon who did that, he went in with that idea that it was a ulna fracture and he needed a shaft plate. And so some of the sets don't, if you have an olecranon plate, an extended olecranon plate versus a shaft plate, that's something to consider what you have in your operating room when you go in to make sure you have those anatomic plates, because some of the forum systems don't have them.
The bone has a kind of a triangular cross section. So if you plate either medially or laterally, you avoid that problem, don't you?
Right. But as you go more proximally, that shape changes a bit. But yes, it is a triangle.
Yes, I find if you plate on either side as opposed to on the subcutaneous border, you avoid the problem. Yes.
Question for Dr. Cardoso. I've seen a reference to reconstructing the interosseous membrane. Is that something that's, I want to say, coming more into the fore?
It is. I've only done it twice, so I can't tell you much about that. So it is becoming much more common. There's actually a system now that Skelodynamics has come out with that actually has a kit that makes it a little bit easier. But yes, it is being thought of much more often and considered more frequently, yes.
Yeah, I think I've done one in 11 years. And at that time was using a tightrope from Arthrex with a combination of tendon graft, but it is difficult to get the right angle and the right tension. It's very humbling.
Do you remember any patients for those?
So for me, it was a case of a radial head fracture that I fixed and it failed. And in sort of exploring how it failed, I realized that his interosseous ligament was incompetent. But I didn't recognize initially, it didn't present as a typical Extremity injury. And the other one I did was it was a sort of more obvious big trauma when we reconstructed the IOL because it was obvious. But in this person that first did a radial head, failed, and then eventually came to the right conclusion that he did in fact have an interosseous ligament weakness. And it's probably seen me a lot more than I've recognized in various patients. There's thoughts that ulnar impaction syndrome as well, because it increases in older ages, is probably due in part to incompetent interosseous ligament. Sir.
I recognize that the correcting the bow and the ulnar was part of the solution for that patient. What about the radial head? Did you feel the need to reconstruct the ligament?
I certainly don't on a regular basis. I think most of the time, if you get the reduction, if you can get the reduction intraoperatively, meaning that it's stable when you leave the OR and you have correctly aligned the ulna, I don't think that's necessary. At least I haven't seen it necessary. I don't know if Raphael has any other thoughts on that.
No, I was going to say that same thing with like Essex-Lopresti injuries. I think there's probably a lot more patients who have Essex-Loprestis that we don't necessarily diagnose. We just see the radial head fracture, and then when we treat it, we're kind of treating the Essex-Lopresti, and as long as their radial head doesn't have a problem, doesn't go into non-union or doesn't displace, then they're fine. It's only when you have to do a revision and you go in and you say, oh, maybe I'll just do a radial head resection, arthroplasty, and then when you go to the DRJ and pull on the radius that you realize that it's translating.
I had a situation with Essex-Lopresti was recognized, but the radial head was, multifragmented, but it extended also to the radial neck. And when the radial head arthroplasty was used, I found myself wishing that I had a modular prosthesis because I could not make up the neck length, even though the correct diameter. And I started to wonder if, I could equalize that situation by doing an ulnar subtraction at the other end, which I figured would be quite difficult to balance. Then I thought about the interosseous membrane, which was the original aspect of the injury. That is still a situation in evolution, however. Just wanted to.
Any other questions? I have a question for Raphael. So do you ever do any stuff with lower extremity with the nerve stuff? So like I had a patient who had a Achilles repair that I did, and it was noted afterwards that when they had their nerve block, that they probably had punctured the nerve proximally. So the patient had no function in their gastroc and dysesthesias on the foot. What is your approach to that kind of case? Have you ever done, they talk about a kind of nerve charging procedure where you take another nerve to kind of stimulate the healing, or do you just wait? Supercharge, I guess is the correct.
Yeah, it depends on what the injury is. I definitely wouldn't do anything acutely. I think I would give them at least 6 or 8 weeks before I get a nerve conduction study to see, and then I would probably follow them for a couple of months. The issue with a nerve transfer is you're robbing from Peter to pay Paul, and so if their soleus was completely intact and their gastroc was the only thing that was weak, I probably wouldn't offer them a nerve transfer because I don't know that. I mean, we know with reconstruction for limbs that we'll take a gastroc, but sometimes both gastrocs for for knee salvage, and that doesn't affect their gait. Now they're not going to be playing sports, but it doesn't affect their gait, and so I'm not going to necessarily weaken their soleus or weaken something else to only get kind of back to where I was. So I mean, I had a patient who came to see me who had what looked most likely like Parsonage Turner, and really only had weakness of the brachialis, which is a weird presentation because usually you see like long thoracic or AIN, and had clear atrophy as brachialis, but had good strength of biceps. And he came to me to get a nerve transfer. I was like, I don't think I'm going to make you better. And ultimately, like, you have good function. Like, yeah, it's cosmetically not the same, but having a bunch of scars and ending up kind of the same strength isn't doing you any favors.
Thank you.
Great talks. This is for Raphael. When you see a patient and you decide tendon transfer versus nerve transfer, you offer nerve transfer, the outcome is not as good as you want it to be, then you use a tendon transfer as an option, as a bailout.
Yeah, I mean, everything, when you're doing nerve surgery, you're kind of thinking 3 steps in advance, and you don't want to burn any bridges. So for instance, the last patient who's recovering AIN but doesn't have any ulnar nerve function, I did tendon transfers for FDP at that time. My AIN's really to try and get some intrinsics back, and I can always come back and do, his ECRL, ECRB were never affected, so I can do a foretail transfer for his fingers to maintain better posture with tendon grafts from palmaris longus, and I can use the EIP for an opponentsplasty if needed.
Following on that, are there any watershed situations where you actually do both? Like you do a neuroraphy at the same time that you do some tendon work? Because it's probably a little too late for one or the other. A little too early, a little too late for just the nerve repair only. And probably on the watershed of time for you to just do outright tendon transfers. Do you ever do both?
I showed a couple of cases where I did do both, one for sensory, one for motor function. But I do try to separate the two because I have all the time in the world for tendon transfers. And so I don't want to, and obviously I'm always robbing from Peter to pay Paul. I'm going to give them some weakness somewhere to provide a new function. And with tendon transfers, unless it's a side-by-side where it doesn't really make a difference, right? They're not going to lose function from it. I don't want, even if they recover, they're still going to have that function, and FDP kind of goes as one muscle belly anyway. I don't want to impede their recovery because of the tendon transfer that I did. So in general, when I'm talking about motor stuff, I'm thinking nerve transfers early or tendon transfers late. Unless it's someone who's really older and doesn't want that recovery, then I might go straight to tendon transfers. But even then, if I had somebody who had a radial nerve palsy from a humeral shaft fracture and didn't want nerve transfers, I would try and kick that can down the road and deal with it later, because I know that they may still see some recovery. I mean, it's not uncommon that we see them bounce back at around a year. The reason I operated on her early was because she had radiation, and I did not feel comfortable that a 40-year-old, even who had been radiated for 30 sessions, was going to see necessarily good nerve recovery from that nerve.
Thank you. I think that's great. I mean, the only thing I would add is that Dr. Galeazzi was truly Colonel Sanders. Was that Pope finger looking good? All right, I'm going to sit down.
All right, we're going to continue the afternoon session. We're going to switch gears and we're going to do a little sports medicine. We have Dr. Papp and Dr. Ross speaking. So Dr. Papp is talking about early AI utilization by a single mid-career surgeon, Momo and Momo AI Pro. I don't know what those things mean, but you're going to be enlightened.
So I wanted to spice things up and maybe make it a little bit, I'm going a little bit off key here. So everybody's talking about robots and all this stuff that's right on the edge. We're talking about nerve transfers. So I thought maybe we could add a little bit of AI to this talk. So, if you look at this is a single surgeon's initial use of AI into his practice in life. I don't have any financial disclosures. There's no conflict of interest. Again, it's a limited study. It's a single surgeon using 2 AI platforms. This is first 40 cases. So again, these are my initial impressions. There is a learning curve. There are some complications, so I do want to share this. So yeah, we'll start with Momo AI Pro. We use version 1.04/7, whatever. It has 40 preset features. You can use text to a final product, and then you can use photo to a final product. So you can ask it what it's going to do, and it'll give it to you. So this is my first use of this. And just wait. Look at this. It's amazing. Totally amazing. Look at how happy they are. And they're totally safe, totally safe. Wait, watch this. This is even better. He transforms. Do you see? It's a beautiful becoming. Watch this. Wait. Things can sometimes get really tense in the exhibit hall. I'm disappointed that my joints colleagues had to do some family stuff because they're robots. Why would you not use this? That being said, there were some complications. I thought Dr. Rose was going to be here. I asked it to make him, I was like, make him into a Batman character, and this is what we got. And so I just want to share my experience with AI. There are pros, it's safe. It cuts you off at 15 videos per week, so you can't just throw money into it, which is good and bad, because I could have sat there for hours. The reason I got into this is, I'm sharing this there. Momo's their initial product. You can use one user with that, so you can use it for talks and that kind of stuff. So somebody turned me onto this because I was advertising for a different meeting. But okay, so look, that's what I fed in, and you feed in 10 pictures of yourself, right? So I haven't had hair since my since I was a teenager, and it refuses to make me bald. So look at that. Look at how cute that penguin is. It's great. Anyway, long story short, pros, it makes you look a lot better than you really look in real life. The cons is it discriminates against you if you're bald. And I felt so bad about myself since I've looked at that I'm going to fly to Turkey to get hair implants before the next TCOS meeting. So anyway, moving on to what I really wanted to talk about was single row rotator cuff repair using an orthobiologic interpositional demineralized bone fiber implant. I don't have any financial disclosures. So the basis of this is that this technique has been already published looking at it from a double row. This is discussion looking at a single row. I preferentially use single row. I think single row rotator cuff repair works well. While there are numerous studies that show that there's results that are better biomechanically with double row repair, clinically, there's really not that much of a difference. There are also biomechanical studies looking at this, not looking at it from like a you know, whatever you want to call a speed bridge type of fashion. But if you take a triple loaded anchor and you tie multiple knots and multiple suture passes through the rotator cuff, that you can get a biomechanically equivalent or sometimes superior outcome. Again, clinical outcomes are solid. The thing that really matters is to get that tendon to heal to the bone. So the question is, how are you going to do that? And if you can create a repair construct that has less tension, it's ideal. This is talking about a demineralized bone fiber implant, so, you know, DBM. It approaches this from an orthobiologic standpoint from a little bit different perspective. Most of the time we're talking about using different kinds of membranes or different kinds of patches for the rotator cuff. This actually looks at a way to increase enthesis healing, so trying to get the rotator cuff to heal onto the bone itself. Again, most of your failures occur at the bone tendon interface. There are studies that show that if you just take DBM by itself and sprinkle it in there underneath your repair, that actually helps increase healing. So those are done in animal models already. This particular implant, it was presented at AOSSM last year, won an award because it kind of attaches things in a different way. This is basically the construct that I use. So again, in that you can see the tendon, oh, I don't have a pointer, but you can see the tendon coming down, and the idea is to park it in a trough that's made right there. I think a lot of people met Dr. Uribe yesterday. That's his method, is to make a trough. So you basically decorticate the bone so that you can actually get the tendon to kind of find a new home. So this is the technique. Again, this is coming from a lateral portal. I'm trying to create the trough there. I don't really like the angle, so I'm going to switch. You're going to see me clean, clean, clean. So now I'm coming from the anterior portal. I'm just kind of touching up the bone. Yeah, I make a deep trough. So cleaning it up so you guys can see it better. Also, so I can get my anchors in. We'll skip a lot of the tying, but I put a couple margin convergent stitches in the back, and then I'm putting in additional sutures, trying to see if it'll come over freely over to the trough, which it does. Again, just cleaning up so we can see. I don't use cannulas. I prefer not to. Sometimes it leads to this, but usually it's good visualization. This is putting in the implant. You can see, look at all the kind of marrow elements that are escaping when you put that in. So it actually, if you look at a SCOE row technique where they microfracture the outside of it and try to get healing potential, this is similar to that. So this is getting deep into the thing, and then this is the DBM implant. So you take that and you just tap it into the bone. And you kind of twist it out. It's actually pretty long, so it does a good job of wicking your healing elements from inside the bone. So you'll see the length of that core as I take it out. It's a lot longer than you think it is. See, look at that. It just keeps coming. Yeah. It keeps going. It's actually pretty easy to put in. So we're going to take it over. I tie different numbers, so I prefer not tying knots. So depending on how mobile the cuff tissue is and how big the tear is, sometimes I'll put 2 suture passes in and then use an anchor that will accommodate that, or this is one that takes 1. It allows you to tension each individual limb. That's why I like this particular anchor. And so it comes out. Just kind of clean it up. And go to the next. So this is what it looks like from picture. And then looking from the lateral portal, this is your final product. Again, I like putting in margin convergence because sometimes that acts as kind of like a ripstop for your repair. And that's about it. Thank you again from Baptist Health International. Hope you guys enjoyed the talk. And yeah.
I didn't know you could fight like that, Suman. Next up, we have Dr. James Ross talking about joint preservation, restoration rather than replacement.
All right, thank you very much for having me to talk about this topic that is very dear to me and exciting nowadays. So joint replacements, you guys have heard about this already today. Very great option for patients that need it. How could we perhaps avoid them? So for the joint preservation, we're going to talk specifically about the knee. So most patients that have knee pain, they present to the office, they have osteoarthritis, and an excellent solution is a knee replacement. But what do you do for this patient who's young, active, has significant knee pain, and has preserved joint spaces? So I think before we talk about some of the different options out there, I think it's very important to talk about knee anatomy. For some of the people that are either listening in, we'll go through some of the anatomy. So the knees hinge portion of the joint is mainly between the femoral condyles and the tibial plateau, and that has articular cartilage, is what I like to tell patients, is the white shiny stuff you see on the ends of chicken bones, and that's responsible for cushion, padding, as well as having friction-free motion of the knee. And just as equally important are the menisci for joint preservation, which is in between. So this is a 30-year-old patient that presented to my office with significant knee pain. And as you can see on their x-ray, they have preserved joint spaces. And what's within that joint is the articular cartilage of the femur depicted in blue, the articular cartilage of the tibial plateau depicted in green, as well as the meniscus depicted in pink. But when we get an MRI, this is what you see. So this patient has medial joint line pain, and on that sagittal MRI where the black arrows are, you can see that the cartilage on top of the subchondral bone is gone. So what does that look like? So at the time of arthroscopy for this patient, with the knee in extension, the photo on the left shows beautiful looking articular cartilage, but once you flex the knee and find the area of the defect, you can see the subchondral bone. And what do you do for this patient? I think in the past, chondroplasty, microfracture were kind of the treatment options that we had, but those are usually temporary and they don't have great durability. Microfracture ends up with a scar type of cartilage that will likely break down with time. But as technology and techniques have developed over time, we have newer techniques that can be used in order to replace the articular cartilage with better articular cartilage, and that's what we'll go through today. So this is that patient, and the option that I chose for this patient was an osteochondral allograft. So what's done in this situation is this patient's MRI is sent off to a graft company, which I like to use as Joint Restorations Foundation, and they make measurements off of the MRI, and when they get a donor that has a knee that's the size that matches your patient, then you get the offer in the email and have time to accept it, and usually time from harvesting to time of implantation is ideal within a couple of weeks. So this donor was a male who's 20 years old, and if you look in the charts, you can see the condylar width of our patient in upper right was 2.7 millimeters, whereas if this donor was 2.6. So an excellent candidate for this graft option for my patient. So at the time of surgery, what we do is we core out an appropriate sized circular plug or donor site for this patient, and then we go to the donor condyle, harvest a plug, and then reimplant it. And you get bone-to-bone healing, and then the chondrocytes or the cartilage cells that are within that articular cartilage are alive and are meant to continue to remain alive for this patient in the long run. But as equally as important as what you do to the cartilage is trying to figure out if there's any underlying factors that predispose them to getting that. So alignment. That's one big thing that we're always looking at in these patients. And if you take a standing alignment x-ray for this patient, you can see that their weight-bearing axis from the center of the hip to the center of the ankle travels through the medial compartment of the knee, which is where this patient's defect is. And in order to have a very good successful outcome, I think that it's equally as important in order to offload that compartment by performing an osteotomy. So what we do is we contemplate the degree of correction and do that procedure and reliably get their alignment back down to the center of the knee. So how do these patients do? This is the best study that I think we have out there. It's a systematic review of 19 studies compiling over 1,000 patients. And these are the numbers that I quote to my patients when we talk about these procedures, is that at 10-year survival for an osteochondral allograft is about 80%, and 20 years is almost 70%. That's pretty successful, especially if you have a young 20, 30-year-old patient. Hoping to get them 20 years could maybe get them till they get their knee replacement in their 50s or 60s, and along the way having a much more pain-free and active lifestyle. But what about not going so far as replacing only the cartilage and the bone? Is there anything that we can do to replace the cartilage alone? And that's where we delve into the restoration, and specifically autologous chondrocyte implantation. So what is ACI? So ACI uses cultured cartilage cells or chondrocytes from your patient to repair this full thickness cartilage defect in the knee. So this was actually performed first in Europe in 1994 and eventually made its way to the US, but it was a very tedious procedure. It worked well, but surgeons didn't like to do it because it was very tedious. Oftentimes you had to harvest a periosteum of the medial tibia, sew it in over the defect, get your cartilage solution, which was liquid, make sure it was completely sealed off, and then inject it under the flap. And it worked well, but it was very tedious, so it really wasn't much in favor. But then the second generation, which is the MACI or matrix autologous chondrocyte implantation, was developed. And that is the cells, rather than coming in a liquid solution, are actually embedded onto a collagen membrane and a collagen patch that you can glue and sew in. And that started being performed in Europe in 2003 with very good success. And then once they performed their studies, was approved by the FDA in 2016, and we were able to utilize that here. So there's three key steps to MACI. The first being diagnostic arthroscopy, where we assess the defect, make sure that they're a candidate, they don't have bipolar cartilage lesions, and see if they need any other sort of meniscus transplantation or anything like that. And then at the time of that procedure, we perform the cartilage biopsy. Second stage, or the second step, is that cartilage is sent off to a lab, Vericel, which is in Boston. They isolate the chondrocytes, they culture them, they propagate them, and then eventually seed them onto a membrane. And then the third step is the second stage surgery, which is predominantly open, but now they've developed an arthroscopic technique, and that's implantation of this cartilage membrane. So during that first procedure, as I mentioned, we really scrutinize the defect, how big it's going to be, because that will determine how many membranes are needed, and whether or not they may have another defect in perhaps the trochlea or the patella, and then figure out the size and make sure that there's no bony involvement. And then we harvest the biopsy. So this is how I like to harvest my biopsy. I used a ring curette on the intercondylar notch, which is an area that's not really articular and can be donated. And we harvest these biopsies, which are about the size of two Tic Tacs. So I try to keep a hinge attached so it's not floating around all over the place, and then I go on a scavenger hunt. And then once those biopsies are taken, we pass them sterilely off the back table onto this cartilage solution. And once we get the patient's information, their defect size, we send it off to the lab. So here's the science. So this membrane is pretty awesome. So it's got two sides. It's got a shiny side, which is a smooth surface, and then it has the rough surface. So the smooth surface is the surface that's eventually going to face the joint, and the rough surface is going to be the surface that actually faces the bone. And that rough surface has multiple interweaving collagen fibers, and that's what aids in those chondrocytes or those cartilage cell attachments. All of the chondrocytes, which are populated, have these cytoplasmic extensions, and it adheres to that rough surface, so that at the time of surgery, that's what gets implanted. So we prepare the defect, we remove all of the diseased cartilage, we get very good shoulders of normal articular cartilage, take off the calcified layer of cartilage, and then I like to use a piece of foil from a suture wrapper in order to template what the size of my implant's going to look like, and then I use that foil, lay it over the membrane, and then cut it out so that I have the perfect size. And then we use a fibrin glue at the base. And then once that fibrin glue is there, we simply place the membrane rough side down within the defect, hold some digital pressure from some time. And then some people, depending on the size of the defects, occasionally I'll like to throw in some 5/0 vicryl sutures. So this is a specific case from one of my patients that had a pretty large central patellar defect. You can see after I fully prepared it in the upper left with that foil template. And then on my glove, if you can kind of see the purplish hue, that's actually the the implant itself, and then after the implant is glued into place. So what happens? So within 48 hours, these cells will actually migrate off of the collagen membrane and adhere to the subchondral bone. And they start to propagate, and they also start to create the matrix proteins and all the collagen that's needed in order to synthesize more articular cartilage and fill in that defect. And it relies a lot on the motion and continuous passive motion machines in order for you to create that, because that's what prevents the chondrocytes from making extra matrix and overgrowing. So actually, therapy is extremely important in these types of procedures. So how do these patients do? So this was the design, this was the trial that actually allowed the FDA to approve this use for the United States. And this was a randomized controlled trial within Europe of 16 sites, and they randomized 144 patients to either microfracture or MACI. And they followed them for 2 years, looking at their clinical outcome scores, MRIs, second look arthroscopy, as well as some patients, the biopsy. And what they found is that 2 years, the pain and function subscales of KOOS significantly improved in both groups, but significantly more in the MACI group as opposed to the microfracture. And then they carried this out to 5 years and showed that the MACI group maintains their pain and function scores, and microfracture starts to tail off. So the clinical success of this, though, is very important on creating a favorable environment for the MACI implant, and that's not only stability, but then also alignment, which we talked about. This was a patient with a very large medial femoral condyle defect. He's 35 years old, and you can see that's the second picture is the MACI implant in place. So big defect, and his alignment shows that there's significant genu varum and the weight-bearing access right through the center of that compartment. And that's his osteotomy to offload the compartment. He's 7 years out. I just saw him 2 months ago, because now he has the same thing on the other side at his left knee, he says is absolutely perfect. And then finally, the third critical component is meniscus integrity. So that's where the diagnostic arthroscopy is very important, because if you see meniscus insufficiency, that's something that you want to plan to do at the same time, or address at the same time as your MACI implant. This is a 35-year-old patient, had a prior prior meniscectomy with loss of the posterior horn. So what do we do for that? This is a meniscus allograft, so similar to an osteochondral allograft. We can send off the MRI and obtain meniscus allograft for transplantation. The beauty of the meniscus is it doesn't need to be as quickly implanted because there's not living cells like the cartilage. So you can have a patient MRI and a selection for a meniscus that can be held for even up to a year. So during arthroscopy, there's several ways to do this. My preferred technique is to leave the root attachments of the meniscus to the bone. There are people doing just soft tissue onlays, but I still think bone-to-bone healing is the best. So I create a bony socket both in the posterior aspect, root insertion, as well as the anterior root insertion, place shuttling sutures, and then these shuttling sutures are utilized in order to deliver the allograft into the medial compartment. So it can get a little tight, so sometimes fenestrating the MCL can be very helpful. And you can sneak that posterior root plug back into its place and eventually dunk it down into the socket. And then once that's in position, tie it over an endo button, a knotless anchor over the tibia, and then do the same thing to the anterior root, which you see right here. Once both of these roots are secured, then essentially you have a large bucket handle meniscus to repair. And you can utilize inside out, all inside techniques for suturing. I like to use still standardized inside out. I think it's the smallest puncture holes, the less damage to the meniscus. I usually try to place about 10 sutures, 10 to 12 sutures, both on the total, both on the femoral and the tibial surface. And then as you get to the front, you can either sew it in through your arthrotomy or use a suture shuttling passing device in order to anchor in the anterior aspect of the meniscus to your capsule, because that's where all your blood supply is going to be. And then once that's sutured in, this is your final product. So you can see now he's got healthy looking articular cartilage, and now he's got a meniscus to hopefully continue to preserve his joint for the long run. So in conclusion, joint preservation surgery in the appropriately indicated patient, and that's very important, has very reliable outcomes for pain and function. And the rapid evolution of these techniques and treatments must be followed by well-performed investigations, which fortunately we have ongoing at this time. Thank you.
Those were both excellent talks. We'll open up to questions.
For that patient who ended up with bilateral. For the patient who ended up with bilateral knee pain, has anyone looked at potentially if you're already treating one side with MACI, doing the corrective osteotomy on the other side as well, rather than waiting till them to be symptomatic 2 or 3 years later?
It's a great option, or a great idea, a great option. The problem is osteotomies, as you're well aware, hurt. And if a patient has a pain-free joint, the likelihood of getting them to buy into an osteotomy is going to be challenging. But I would argue that that's the whole reason he developed the cartilage problems that he had. So I think an osteotomy would be great and would probably prevent it, but getting someone to buy into it or even insurance to pay for it would be difficult.
Dr. Ross, the bucket handle repair you just showed, how long is the person after they do that? How active can they be after? And how long does it take? Can they do sports or et cetera?
Great question. So my rehab protocol is to have those patients partial weight bearing for 6 weeks more to protect the root insertion, with an ultimate return to their level of function at about 5 to 6 months. There's actually more data on the osteochondral allografts, the cartilage plugs for return to sports, and especially at high level. I think that once you get to the point where you need a meniscus transplant, you're counseling the patient that, you know, we just did a big procedure to try to preserve your joint. It's probably not best for you to be involved in high level activities. However, I've had plenty of patients that, you know, a police officer who plays pickup basketball, a dentist in town who plays ice hockey, like they go back to playing sports.
Dr. Ross, if and when you come across bone bruises in your practice in some of those patients, do you have an algorithm for assessing its contribution to pain and how it itself is managed in those circumstances?
Awesome question. Bone bruises hurt like crazy, as you guys know. And I think that now that imaging is getting better, we're picking up reasons why they happen. So the whole spontaneous osteonecrosis of the medial femoral condyle, I don't think that's an avascular necrosis. That's like a root tear of the meniscus. That's like a radial tear of the meniscus that we didn't really appreciate before. So a lot of these patients that have the bone bruises, I try to figure out why. So if they have a radial tear of the meniscus and it's a young patient with an acute injury, I'm arguing hard for them to try to do surgery. But if it's a 55, 60-year-old patient with a root tear, they're overweight and they've got bone bruise, you know, for them, I'm talking more about offloading braces, injections to try to get them through. But I think that if you do things like unloader braces and modify their activities and you get their bone bruise to heal, I think their pain goes substantially down.
Do you ever do subchondroplasty for those or no?
I'll do some chondroplasty if I'm going to surgery for it. But if an isolated bone bruise, I try to offload them first before doing that, but if need be, yes.
Essentially, you are awaiting its resolution before going on to the cartilage lesion.
It depends. So it depends on what the cartilage looks like on top of it. So some of those patients can have bone bruises with normal articular cartilage that hasn't broken down yet because the bone is starting to sense increased pressure. And again, something happened. You know, something happened to that patient, whether it's a root tear or radial tear. If that cartilage is intact, that's a dramatic change in the nature that the bone is seeing and feeling that caused that bone bruise to happen. On the contrary, when you have a full thickness cartilage defect that's there with a normal meniscus and bone bruising, that's a different animal. And then that's something that I would be more pushing towards, like an osteochondral allograft, replacing both the cartilage and that unhealthy bone, because the subchondral bone is usually pretty involved too.
Good talks. Both talks were good. Dr. Moss, in my setting, I find root tears to be an underdiagnosed lesion. And I typically find them most of the time at the time of arthroscopy, rather than as a diagnosed lesion from the radiologist. What is your view about the avulsed meniscus? Do you think we should look for root injuries for those observed meniscal pathologies?
Absolutely. And I think sometimes the imaging is, if you have a 3 Tesla MRI with thin slices, you can usually see it. But some of these patients that come in with MRIs that are already performed, it's hard to make it out. You can get an assumption, and sometimes looking at the coronal MRI and seeing if there's any meniscus extrusion. If I see that, then I really try to scrutinize the root. And if I think there's a root tear there, I'll either repeat the MRI or tell them that there's a good chance that that's what we're going to do at the time of surgery. So a patient with healthy cartilage with a root tear that's young and active, I think a root repair is a very good option. It's a difficult, challenging recovery, but I think our surgical techniques have evolved to try to get it to heal better. And there was a recent study that was done at Mayo Clinic that they actually use a centralization suture. So in addition to the root sutures tacking it down, at the mid-body of the meniscus, if you put a suture anchor, usually a knotless suture anchor into the tibia, and incorporate that through the meniscus capsule junction at the mid-body and bring it in, the successes of your root repair are even greater.
Yeah, I was going to say Aaron Critch's work at Mayo, he's done a lot of work on that. And I think if we get it to those earlier, we help prevent people to get into, later arthroplasty situations.
Right. Question. What's your rehab protocol like for the MACI, for the patella? And with such a large defect, how does it compare to just resurfacing the patella?
So it's much longer. So I tell patients that full incorporation of the MACI implant is about a year to a year and a half. So they all get CPMs for 6 weeks. Patellas, I usually let weight bear earlier than femoral condyles. So I'll let them weight bear an extension usually at three weeks. But loading with like knee extension and squats, I mean, you're talking about 2 to 3 months after surgery before even doing just body weight. So it's a long, long process, and you just got to make sure that the patient is bought in. And often that's a reason why we don't do it on young athletes who have seasons to go back to, is because they can't afford missing 1 to 2 seasons, as opposed to an osteochondral allograft. Return to play could be 7 to 9 months.
For your, Dr. Ross, allograft replacement, is it more, what's a typical patient in terms of an indication, and what patient is it contraindicated in? And I guess a general question is it more to try to replace function, or it's a pain control? Ultimately, you're trying to delay the need for a joint replacement, but is it more for the patient with functional issue in terms of stability, or it's pain?
Which replacement? I missed the beginning.
The allograft replacement of the meniscus.
The meniscus allograft.
Yes.
Okay. Yeah, so that's more for the patient who has pain with meniscus insufficiency. And they're usually patients that have already had a knee arthroscopy. So someone that's, 30 years old, normal looking cartilage, you get their MRI and you can hardly see a posterior horn anymore. That's the ideal patient for it. And the idea is to do it to delay the need for a knee replacement. So contraindication for me would be bipolar changes or significant chondral loss on the femoral condyle. Because I think if you have a focal cartilage defect on the mediofemoral condyle with meniscus insufficiency, and they're young and active, I still think that they're a good candidate to do both the meniscus transplant and some sort of cartilage procedure. And there's very good data to support that.
There's final one really. This is probably a theoretical question. We all grew up on concept of coronal alignment, or certainly importance of restoring that. Is there any concept of a sagittal alignment important in the knee?
Absolutely.
That's
I mean,
great question.
That is the hottest topic right now in ACL reconstruction, is tibial slope. I mean, this is huge. So, and I actually did 2 corrective sagittal alignments in the last 2 months for people that are on their 4th ACL. So tibial slope greater than 12 degrees right now is kind of what people are recommending, not in the primary setting, but in like a revision ACL reconstruction setting in order to do a slope reducing osteotomy. So it's not uncommon for Tuesday. So Tuesday I did a case. She's had 2 failed ACLs, 1 allograft, 1 autograft. Tunnels were in pretty good position. She has medial meniscus insufficiency, but when you do her exam, I mean, it's like the Lockman that the medical student can do. Like you can see it from across the room, and she actually, you could lock her on a pivot shift test. So those are the patients that, you know, you worry about just doing another ACL. So this concept of sagittal alignment and tibial slope is huge right now, and there's actually some new osteotomy companies that have come out with custom osteotomy guides to do these types of procedures.
You use that, right? The new
Body CAD, yeah, we just got it in. So, and it's awesome. It's unbelievable.
How do you go about treating the relatively young patient with a neglected ACL and possibly some early joint pain?
So depends on their activity level. I mean, if they're running around trying to do things or even the knees giving out on them during their normal activities of daily living, I think an ACL reconstruction is important. The chronic ACL, where they start to stretch out the extracapsular structures, I think a graft alone, especially if their tibial slope is a little elevated, is probably not enough. And I think that that's where these procedures, like a lateral extraarticular tenodesis, can be very helpful. So if I have someone who comes to me and they say, yeah, I tore my ACL 5 years ago and it's just finally bothering me enough to do a reconstruction, and they have a very loose Lockman's and a very high-grade 3+ pivot shift, not only are they getting, in my hands, a patellar tendon autograft ACL, but they're getting a lateral extraarticular tenodesis with iliotibial band, just as backup biology to help keep the knee stable during that ligamentization process of the ACL. Because I think if you ignore all of that extraarticular laxity, I think as the graft is healing in, it just stretches out, and then eventually it's going to give.
Dr. Ribas, you had a question?
Thank you, Dr. Cardoso. With your permission, we have a question from Dr. Randolph Carrington from Barbados that says, Dr. Ross, do you allow partial weight bearing after meniscus graft? I'm sorry, you do allow partial weight bearing after meniscus graft. Do you immobilize the knee at all?
Only for the first 5 to 7 days until I see them at my first post-op. They're locked in extension. And then for partial weight bearing, yes, I think that complete non-weight bearing, I think just ends up in more atrophy. So I do like to use like 20 pounds partial weight bearing the foot of their, or the weight of their leg. I think that that's safe.
I had a question for Dr. Papp. So using the DBM fiber implant, do you feel like it's changed your clinical practice? Do you get people back to moving faster? Are you less cautious? You seen a difference? And has there been any complications? Do they ever come out? Or is there a fracture in the process of putting them in?
So I'll work backwards. I haven't seen a complication yet. It's pretty easy to put in. In terms of my rehab protocol, I'm pretty aggressive with my rehab as it is. The initial studies on this thing show that it increases, and this wasn't done in a person, it was done in sheep, but the pullout is better faster. So theoretically, you can let them do more faster. The idea is, again, to get that, promote the tendon to bone healing faster. Has it necessarily changed my practice? No. I think, again, I had this talk with Mark Gettleman, but it was like, for the vast majority of the cuffs that we fix, you don't really have to worry about them. It's that whatever 10 to 20% that the Rohi score is high, and you want to do whatever you can to make it heal. And this is, I think, another tool in your toolbox that you can use.
Cool. So great.
Do you have a size rotator cuff tear, A to P, that you're thinking that this is for?
Yeah, I mean, this is more your massive cuff tear, your tear. I mean, again, you can use it in older patients because it potentially helps with the healing. Revisions as well. Yeah, I just had a big revision on, I forget if it was Tuesday or Wednesday, but I made a joke with my staff about using everything. And that was one of the things I used.
Great. Sorry. When it comes to cuff tears, the older patient with a thin cuff has a higher risk of re-tear, even though good surgery was done.
Yeah.
And so augmentation with a similar type scaffold has become quite popular, like Regeniten, for example. What is your view about using a bioscaffold like Regeniten to thicken the cuff as an end result, rather than the bioscaffold that you use, which was like a bone plug
So
to transfer material to the cuff?
I think your question's excellent. I think there are different ways to attack that problem. I think using those kind of membranes is great. You know, again, if we're talking about certain products, Regeniten has a good amount of data that shows that it works. There are papers that show that it can have an inflammatory effect on patients, which I think is actually positive. I think it shows that patient that there's actually healing there, but it can be frustrating for the patient at like the 2-month, 3-month mark because they get kind of inflamed, they get kind of angry. There are other products out there that are similar to that. But it is something that I use quite commonly in my practice. And before this thing, I will use them together. Like if you have really bad cuff tissue and I can put that in there, I mean, why not give the patient the best chance to heal?
All right, I think we're wrapping that session up. Thanks, everybody.
Thank you.
Thank you.
We are going to switch gears and talk about sarcoma. Dr. Patel is first up. He's going to talk about outcomes of unplanned excisions of soft tissue sarcomas.
Hello. So thank you, Roy and Derek and the International Department for putting this together. It's a very good opportunity to listen to all these new things that are happening now in orthopedics and also to not so new, but always interesting to listen is these topics about tumors. So guys, from you, who do you have the chance to see like soft tissue masses, sarcomas in your practice? Do you have a cancer center there in America? No. Okay. Do you have access to different adjuvant treatments, radiation, chemos? Okay, good. So what type of multidisciplinary approach do you use? Do you have tumor boards? Or is kind of press and broncho? Okay, good. Okay, so okay, so that's good. I mean, ideally, you know, this patient should be treated in general in big cancer center with big volumes in order to have, you know, the optimal outcomes. But you know, you can do whatever you can to help these people. So this topic of unplanned excisions, it's something that I have been working with since I started my career, like 11 years ago. I have no disclosures. So that is a patient I saw when I was in fellowship. That was my first patient that I saw with an unplanned excision. Funny fact is that he was very happy because the surgeon found that he had a tumor. So that's something that really caught my attention because it's something that
when you do these implant excisions, you potentially can have very bad outcomes, oncological outcomes. But then you have to deal with the psychology of this patient that loves the surgeon that referred to me. And you cannot say anything, bad about the surgeon, but also you are kind of frustrated because now you have to deal with a very complex, very complex problem. So this guy, 58-year-old male with pain and swelling in the right upper extremity. The short story is that he was lifting some heavy weights and felt like a pop. So initially he was diagnosed like a tendon tear, right? So he went to the orthopedic surgeon and, tendon tear, blah, blah. They did that CT and you can see, some like a mass effect there, right? But it was, interpreted like a hematoma. And so they decided to repair the tear and drain the hematoma. And they went in, they started draining, and drainage was not really blood. It was a little bit funky with, solid pieces. So then they decided to send it to pathology, and it came as a high-grade sarcoma. But what you can see there are different things. So how they close the wound. Very wide sutures. All that hematoma that was left after. And then here you can see the lateral aspect, not even in the same, line with the surgery. So, they did several things that were not correct. But then, well, they referred to see us, right? So this was a case that kind of introduced me in the topic. And after the day of clinics, I went to home and I started looking in the literature to see what was there. And there were a lot of different, articles, but there was not like something together, like to say, okay, let's see if there is a review article or something like that. And there was nothing at that time, and so we decided to write the first current concepts that was published in JBS in 2015. So this was a patient that introduced me into the topic. So this, this topic is not new. The term implant excision is already known since the 80s. The basic concept is a tumor resection without preoperative diagnostic modalities, or if they have the modalities, the interpretation is not correct. And the intention when they do the surgery is not to achieve any free margins because they don't know that they are dealing with a sarcoma. Now, the problem is that these sarcomas are very rare and is unsuspected. So there is not an adequate evaluation of these patients. And remember that benign tumors are much more common than this. So the human assumption is to say, oh, this is a benign tumor, this is a lipoma, whatever, or hematoma, right? And then you fail and you're surprised that it's a sarcoma. So who are involved in these type of surgeries? Usually plastic surgeons, general surgeons, and unfortunately orthopedic surgeons also. So several studies have reported that these implant excisions represents about 18 to 66% of new patients referred to sarcoma centers, and that's something that I can attest. That, for example, this case is a patient that was seen by a hand surgeon outside, community hand surgeon, and so he saw this patient with that mass, right? He did an MRI. I mean, he has suspicious of, what is this? But the report of the MRI came as a schwannoma, right? So he kind of, okay, it's a schwannoma. Then he opened this, removed the tumor, sent it out. It was a high-grade sarcoma. And that's a particular thing, right? Because our teaching, classic teaching is, okay, big tumor, more than 5 centimeters, deep, down to the fascia, suspect this is a sarcoma. But also sarcomas exist in the upper extremities, superficial tumors, and even like you can say up to 30% they can be sarcomas within the sarcoma group, right? So then we have this problem, right? I go to the office and then I'm surrounded of these patients, right, with all these unplanned excisions, and then I have to do what I say a backwards workup, right? Because here the patient comes already with the tumor out. So I have to go back like a puzzle and try to see what was done and start gathering information to see what's the best treatment approach. These patients, regarding the age, will be the same as patients with sarcoma, mid-50s, is the same profile. History of trauma, so this is important because in general, right, many patients with soft tissue sarcomas will have a history of trauma, some kind of trauma. You ask the patient, hey, do you have a trauma? Oh yeah, 20 years ago, I fall from my bed. No, something more recent. Oh yes, I had this. And that's human nature. People will try to explain why they have a mass. So the easiest thing to do is to say, okay, yes, I had a trauma. So regarding the size, right, these tumors, these patients with unplanned excisions usually will have superficial tumors, small tumors, upper or lower extremities. Most commonly, probably upper extremities. The other thing is that the most common misdiagnosis, right, in these patients will be either a lipoma or a hematoma, right? The problem is that, for the lipomas, many times, a lot of physicians, they only touch the patient, they see, oh, you have a mass, probably it's a lipoma. And probably they will be correct. I mean, because lipomas are much more common, but they don't go further and they don't do not even an ultrasound or an MRI, right? When you're thinking about a lipoma, doing an MRI is very easy, and you can diagnose that without a biopsy or anything like that. So, but sometimes they don't want to do that extra step, and they leave it like that, and then there is a problem. Resection is not a lipoma; it's a sarcoma. And the other thing, very common, hematomas, right? And the problem is that the high-grade sarcomas, they can bleed. They can bleed inside. So they will look like a hematoma. So then you have to go a little bit more into the history of this patient and say, okay, this patient had a trauma, right, that can explain the hematoma. If this patient has any blood discretion, that can explain spontaneous bleeding. This patient is taking any anticoagulation treatment, that can explain this bleeding. So you have to kind of go a little bit more deeper in the history of the patient to see if a hematoma can be explained or not. The most common pathologic diagnosis will be, so this is a study that we published in 21, and you can see the difference in planned excisions. The most common sarcoma is the UPS, undifferentiated pleomorphic sarcoma, or also is called myofibroblastic sarcoma. And then in the unplanned excision is the myxopharosarcoma, right? And that tumor is a little bit of a problem because it's very aggressive locally. It grows in an infiltrative pattern, very difficult to resect with negative margins. So you can imagine if, to the fact that I have a tumor that is really a problem to resect as a planned excision, if you add the additional contamination that you can create with an unplanned excision, then it's a big problem for local control. Now, regarding the classification of these procedures, you can have, total unplanned excisions is where nothing is done, right? And the surgeon goes, boom, remove the tumor. And the partial unplanned excisions, right, where some kind of workup is done. You can do an MRI, you can do ultrasound, you can do something, trying to see, or even a biopsy, right? But the problem is that everything is malinterpreted. The biopsy is not reviewed by a MSK pathologist, so you have an inadequate
diagnosis. The MRI, even though it's read by a radiologist, then they also get a bad, a bad interpretation. So then you have, to be depending on other specialties that they should be correct in order for you to have a good, information and a good decision making. So that's why it's important that even if you have some suspicious for a soft tissue mass to be a sarcoma, really don't go, deeper on that and trying to refer to a specialized center, because it will be a much, faster intervention in the patient. So when you have an unplanned excision, what I like to do is to ask 3 questions to myself. First, what was done to the patient, right? And that's the detective game that I was talking about, to try to build a puzzle. Then, what is going on with the tumor, right? Locally and systemically. And lastly, when I have all that information, then I can ask myself, what should I do at that point? So the management following an unplanned excision should be done in a multidisciplinary approach in a sarcoma center. The treating team should gather operative report, right, to see if there were multiple masses removed, what approach was used, potentially what tissues were affected, diagnostic imaging that was done before the resection, pathology reports and histology slides. That's super important, okay? There is Lord Randall from UC Davis. He published a few years ago that up to 37% of the diagnoses were incorrect. So if you start, your treatment with an incorrect diagnosis, then you have an incorrect treatment, right? So first thing, pathology reports, histology slides. Those should be reviewed 100% of times. And then you also have to ask about any treatment that the patient could have before, right? More resections, maybe they start some kind of radiation or chemotherapy, whatever. But you have to know exactly what was done. Then, of course, start with physical exam. Go into and see the surgical site. Very important to see the skin incisions that were used. Usually, transverse or oblique incisions are a problem because they cover much larger surface. So then your resection will be much bigger. That can compromise the lymph function. Also, it can end up using more complex procedures for closure, like muscle flaps, local flaps, free flaps, tissue rearrangement, etc. And also, the radiation fields can get wider because you have to cover much more surface of contamination. Also, you have to see the hematoma, presence of hematoma, because this potentially can increase the contamination beyond the area where the tumor was. And the use of drains, basically to see if they were trespassing other compartments that they should have not trespassed. Finally, skin closure. It has to be done, by layers to reduce the dead space and as thin as possible, to trying to have less resection area. Regarding the tumor, okay, what is going on with the tumor? For that, we do what we know as staging of the tumor, right? Or the patient. So a local staging, the minimum we have to do is an MRI, right? To see how is looking the surgical bed, right? If there is any macroscopic tumor left, or there is only post-surgical changes that can indicate that there is some microscopic tumor that was left there. And distant staging, at least a CT of the chest, at least. Depending on the type of sarcoma, then you can do further workup, CT chest, abdomen, pelvis. There are some soft tissue sarcomas that are more prone to have other metastases, other even bone, right, like the myxoleposarcoma that
It can go also to the bones. So for that specific soft tissue sarcoma, you have to order MRI of the spine, for example. But it will depend on a case by case. This is a case of a pleomorphic myxopharosarcoma, post-implant excision. That was a tumor, right? And then they did the excision. And in that case, pues, there was, microscopic tumor that was left that we saw in the tumor bed after the resection. The problem with the imaging studies is that they are not as accurate to tell you if there is tumor or not. There are some articles, right, like the ones that you can see published there, but you can see that the sensitivity of this MRI really goes down, like around the 60s, 70s, in order to detect, residual tumor. The other problem is that these tumors also can affect, right, the oncological outcomes of these patients, and you can have increased local recurrence of the tumor, but also in some centers it has been described that you can have decreased overall survival, even though that is not totally accepted as an outcome in this type of procedures. Regarding the treatment, you have three things that you can do: the tumor bed excision, which is a re-resection of the surgical bed. You have radiation and chemotherapy. The radiation and the chemotherapy follows the same principles as for the planned excisions. Regarding radiation, we usually use the protocols like if it was pre-op radiation. Even though you already had surgery, the protocol that we use is like a pre-op radiation protocol. And that's something that is used, across all institutions. The tumor bed excision, the goal is to remove residual sarcoma, either macroscopic or microscopic, and potentially the contaminated tissues that are around with negative margins. The rationale for this is that there could be, gross or microscopic residual disease, and is often present following unplanned excisions, which has prognostic implications. You can see there, that's a table that from the current concept that we published a few years ago, and you can see that there is a high percentage of re-resections that have tumor present on the tumor bed, right? So there is always, tumor that is left on the surgical site. Regarding the treatment, the surgical treatment, there is two approaches. Here in the United States, and I think almost all over the world, except French people, we are very aggressive with this, and we do re-resections. Okay, so that's kind of the gold standard for this. However, you can see those two groups. One is from Italy and the other from France. That they try to do the wait and watch approach, meaning that okay, you have there, you don't see really macroscopic tumor, no? So then you wait and see if there is a recurrence or not. The problem with that is that there is literature saying that when you do that, when you have the recurrence, then potentially you can have implications with a worst overall survival. So then that's the question, right? I mean, if we wait, then it will recur, and then potentially the patient can have worst overall survival. So that approach, is a little bit more complex to follow. These studies say the same thing. 5-year overall survival. You can see the local, if there is local recurrence in the group of local recurrence, the 5-year overall survival will be lower. No? So there can be that impact. Tumor bed excision has been found that is an independent predictor for local control, right? The tumor bed excision should include resection of prior operative incision.
inclusion of adjacent cuff of skin and soft tissues based on operative report, pathology reports, physical exam, and MRI. The adequate surgical resection is difficult in this case because of the presence of a scar, loss of normal anatomical planes, and many times when there is microscopic tumor, you really are not touching the mass. So it's kind of, you were kind of blind, no, to do those resections. And we published also this article regarding the accuracy of intraoperative assessment when you are doing these re-resections. And we found that, in a center with a specialized MSK pathologist, you can have a very good accuracy in detecting residual tumor and evaluating the margins, very similar to planned resections. And that's important because if you find, positive margins intraoperatively, then you can do a re-resection at that time. And that can save, trips of the patients again for re-resections later on. The other question is, okay, I have this patient that had surgery, 1 month ago, and when should I do the surgery? In reality, there is not too much research about that, the optimal time to do this re-resections. This study is the only one I have found by hand, and they didn't see any difference in local recurrence rate regarding the timing when you do the surgery. They divided their group in 2 groups, 32 days, like the cutoff. They didn't find any difference. The question of the $1 million is how much should be resected, and I think that if you see in the upper right hand side, that's a very good, nice example. Nurse get into the internet, go to surgery.com, scroll down, and click on "Are you totally lost?" No? And that's sometimes how we feel, because you don't have tumor palpable, you have an MRI with a bunch of edema, a surgical site with a drain, going to different compartments, and you're like, how much should I resect? In that sense, some authors, they recommend 2 centimeters, 3 centimeters of margin around what you believe it should be the contamination on an MRI, no? But in reality, there is not a good answer for that. And as a consequence, right, because you are doing these massive resections, then these tumor-bed excisions are very morbid, right? And it has been shown in previous studies that the need for flaps, skin graft, local flaps, free flaps is higher, right, in these cases. So it's very important when we have these patients to have a very good relationship with plastic surgery in order to plan, the coverage, the closure of these in these cases. That's another important issue, when to close this patient, right? Now I am a little bit more careful, and I probably almost all the cases of unplanned excisions, I do stage closures. I do the resection, send to pathology, and wait for margins. In the meantime, I use GUM back systems. And then when I have a negative margin in pathology, then I coordinate with plastic surgery to close the patient. But also, not only will have impact on the patient itself, but also in the health system, because these cases also are more costly. Patients stay more in the hospital, so everything is a little bit more expensive when this happens. And you can see there in that article that plastic surgery is important, because you can have in these cases skin defects that are larger in the unplanned excision, and also the need for, as I say, for more complex closures. This is a recent systematic review and meta-analysis that we published 2 years ago. And this is the largest study published on this topic. 16,949 patients included. Of those, 6,017 unplanned excision, 35%. More or less, that's kind of the epidemiology on these cases. And you can see there that, for example, plastic surgery reconstruction, it's important. I mean, there will be a higher need for plastic surgery reconstruction in those cases. And this is the study I was talking about, the cost, right? Patients with unplanned excision will have more surgeries. It will be more costly, the management, and the hospital stay also will be longer. Radiation, it has not, really, we don't understand really well how much the radiation what's the role of radiation in these cases. However, in most recent studies, it has been seen that preoperative radiation improve the local control in these cases. So in my practice, I usually, try to do preoperative radiation in these cases, and then do the resection. No? So more or less, these last 3 articles that I show more or less the same control rates with preoperative radiation in the 90%. However, there will be some patients in which you cannot do surgery because it's too morbid, and you can try to do only radiation. And it has been seen that the results are acceptable for those cases with local control, which that is pretty good, as you can see in this article from Mass General. However, it's a little bit old. It's from 2005. Chemotherapy is the same protocol as the management for planned excisions. Chemotherapy basically is used for high-risk patients for metastatic disease, patients that will have tumors more than 5 centimeters deep and high grade. Regarding the prognosis, the 5 years local recurrence-free survival will be affected by the unplanned excision. It will be decreased. The 5-year overall survival, we didn't find a difference on overall survival in these patients. However, there is the group from Toronto with Jay Wander that they have published one big retrospective study, like with 500 patients, and they found that there was decreased overall survival in those patients. And also from the same group, they published another paper recently with small soft tissue sarcomas that are superficial, and they also found that unplanned excision was affecting the overall survival. However, they are the only ones that have found this. So I don't know if Canadians have different problem than us. Residual disease at 5 years, local recurrence-free survival is also affected by unplanned excision. So that's the proof that we were talking about, that why that wait and watch approach can be a little bit dangerous, because if you wait for a local recurrence, potentially the overall survival of the patient will be affected. The 5-year overall survival in recurrence of disease also will be decreased, right? So that's the importance of trying not to have a recurrence in these cases. Now, regarding amputation rate, it has been published in the literature that usually these unplanned excisions will have a higher amputation rate. However, we, in our systematic review and meta-analysis, we didn't find that difference. So, it will depend a lot in case by case how much, morbid you have to do the resections. So in conclusions, these unplanned excisions are still a significant problem and volume of referral to us. The best way to approach is with prevention and education, trying not to have these unplanned excisions done. The tumor-bed excision is the standard of care. Radiation nowadays is moving towards neoadjuvant radiation in these cases. Chemotherapy, same guidelines as planned excisions. And basically the oncological outcomes that will be affected will be local recurrence, 5 years local recurrence-free survival, and the overall survival and metastatic disease probably is not affected in these patients and is more dependent on the grade of the tumor rather than the procedure itself. Thank you.
All right, I hope you guys are in the mood for more talk on sarcomas because Giovanni Barlatici is going to talk about diagnosis and treatment of soft tissue sarcoma.
Good afternoon, everyone. Last but not least, okay. I know you guys have been here all day. It's kind of tired. I will try to be as brief as possible. I want to thank Dr. Ribas, Maria Vila, and the entire group of Baptist Health International Group for having us today and to share our experience and our passion of what we do on a daily basis here at Baptist. So as I said, I'm Giovanni Paralitici. I'm an orthopedic surgeon. I specialize in orthopedic oncology and also in total joints. I love complex and big cases. So why is this topic is important? Everyone here in the room has a family member, a friend, or even a personal experience dealing with cancer, some kind of tumor or malignancy in our life. This is a condition that does not discriminate, doesn't matter gender, doesn't matter race, doesn't matter any social economic status, anything. So someone in our life is going to be affected by this condition. It's a rare, there are multiple subtypes. Less than 1% of the entire cancers in the world that are diagnosed are related to sarcomas. And in the pediatric population, it's less than 7%. Talk a little bit about, there's two types of sarcoma. There's bone sarcomas. Primary bone sarcomas are extremely rare. The most common type are osteosarcoma, Ewing sarcomas, and chondrosarcoma. The most common malignancy in the bone is, however, metastatic disease. And then we have the soft tissue sarcomas, which is a cancer that is derived either from the muscle, tendons, cartilage, blood vessels, or any fibrous tissue. As per the American Cancer Society from 2024, 14,000 cases were diagnosed in the United States. That is very rare compared to other cancers, but it's increasing in frequency. More common in male now than in females, and 5,200 are expected to die from sarcoma in a year. As Dr. Patel mentioned in his talk, benign conditions are more common than malignant in a ratio of 100 to 50 to 1. And as per 1 million people in the United States, 20 of them will have a sarcoma. So that tells you how rare it is, but we're going to encounter there, especially in a specialized institution. Dr. Patel mentioned this as well. The most common soft tissue sarcoma in a planning scenario is in undifferentiated pleomorphic sarcoma, liposarcoma, and leiomyosarcoma. Common in the extremity, lower extremity twice as more common than the upper extremity. These conditions are mimicker. So you think you can have an infection, you think you can have, as Dr. Patel mentioned, a trauma, which will bring it to the attention of people. But it's not, you're trying to come up with excuses like why I have a lump there and it's been growing over the last weeks or years, depending on the type of cancer or tumor. A little basic concept, kind of Dr. Patel mentioned, but I'm going to kind of play it as simple as possible. Sarcomas, we talk about it, but adjuvant treatment and neoadjuvant treatment. What's the difference? It depends on the type of cancer. Neoadjuvant treatment refers any chemo radiation that is given prior to surgery, and then adjuvant therapy is chemo radiation after surgery, okay? And then radiation. What happens when we get preoperative radiation or postoperative radiation? In sarcomas, after we discuss our cases in the sarcoma tumor board, there's a consensus from our multidisciplinary team, and we provide the recommendations that we understand as per the clinical guidelines are the best for this type of tumor for our patient. And in the preoperative setting, there's a higher risk of wound complications. The recurrence rate is pretty similar from pre-op to postoperative radiation. It can be given now in a hypofractionated manner, meaning you don't have to wait the 12 weeks, which was the standard time that was given back. You can give it in 3 weeks, the dose of radiation. So in total dose, you get less amount of radiation. In the setting of post-operative radiation, it's going to be a larger field. It's going to be a larger dose of radiation, and this is going to increase the complications such as fibrosis, stiffness, and most likely edema. Chemotherapy. When do we recall or try to use the role of chemotherapy as per recommendation? Mostly are in the setting of a tumor that has the potential to become systemic. Those tumors that are big, that are deep to the fascia, greater than 5 centimeter, or a high-grade tumor, those are the ones that we normally recommend to undergo chemotherapy. And the type of chemotherapy is an agent-based protocol that is given to the patient. I cannot emphasize on how important is the history and physical examination. You'll be surprised about how many patients will walk into your office and say, "Doctor, you're the first one who's really touching this mass and examining me and seeing how I move my arm or my leg. No one just touched it before. They just say, oh, you have something there, go this, get the study, and then do the surgery." So it's imperative that we need to examine the patient. With the physical examination and the history, you can get the diagnosis or a differential diagnosis in about 60 to 70% of the time. And then we combine that with imaging modalities, and we combine also with a biopsy to try to get a diagnosis or a differential diagnosis. Don't get fooled that painless mass, because painless mass may be both benign or malignant. Questions that I like to ask the patients: how long have you had that mass? Is this growing rapidly? Is it growing slowly? Did you ever had any history of any accident, any history of radiation, any prior history of cancer, any family history of cancer? Is it painful or not? Is there any unintentional weight loss, any fever, any night chills? Even though these are classic signs and symptoms of some kind of malignancy, they don't happen in all the patients. So we always have to be aware that any mass that we encounter, we should always think that is a malignant. As Dr. Patel mentioned, this is a classic interpretation. Any deep mass greater than 5 centimeter that is very firm to the fascia is a concern for a malignancy. But the superficial mass, a third of them may be benign. So the rest of them, the 67%, may be malignant. So bear in mind and remember that, please. We combine the examination with transillumination. If there's history of trauma, if there's any shooting pain, is there any improvement that help us kind of start making our differential? And if there's any regional lymph nodes, there's certain type of sarcomas that they spread out to the regional lymph nodes, and this is a concern for malignancy, such as synovial sarcoma, angiosarcoma, epitheliosarcoma, and some like that. I get asked this question very often in the office: "Doctor, is there any blood work that can tell me if I have cancer?" And the question is, there's not 100% specificity for a cancer, but there is some suggestion that they may be associated with some kind of tumor or some kind of cancer. Molecular testing, I don't know, they asked ChatGPT and we'll give it the answer or not, but tumor markers nowadays, like PSA for prostate, help you guide your treatment and kind of be indicative that there may be some prostate malignancy, such as in the alpha-fetoprotein for liver, okay? But it's not only one blood test or one specific test that will tell you you have this type of cancer. You need to combine it with other modalities. And then that's when we also add the images. And then the most simple one that we forget about, X-ray. Most of the time, I will get a patient with an MRI and not having an X-ray. I don't know how that happens, but it happens. We can tell a lot from the X-ray. And like in this X-ray, it's something that is quick and inexpensive. You can see a heavily calcified mass in around the left hip. So that tells you this doesn't look benign. This looks like angry looking. So that is suggested that something is happening there, okay? And there's some other examples that we see here in the far left. It's a skeletally immature individual with a soft tissue mass in the forearm and some round calcification. So that kind of lets you know this possibly may be a hemangioma, okay? This image in the middle, you see a heavily mineralized mass in the back of the distal femur. That doesn't look good either. So that may be an extraskeletal osteosarcoma. And then the far image to the right is an X-ray of the elbow and a patient with a history of trauma, and you see that calcification anteriorly. So you kind of start putting pieces together and say, maybe this may be like an myositis ossificans, okay? But again, You cannot diagnose these conditions entirely with one image modality. Okay, and then you combine this with the gold standard, which is MRI. And then MRI will help you, it's very sensitive. You add contrast to this, and it'll help you distinguish if the mass is solid, is it cystic. It can help you also guide for the treatment, for the needle biopsy, for the core needle biopsy, which is the area that will be more sensitive to provide us with the diagnosis. And in the case that patient has a recurrence, it can help us distinguish scar tissue versus recurrent disease. Okay, so all of this is to help us decrease the amount of what Dr. Patel was talking about, unplanned excisions, and try to coin the best diagnosis for the patient. Some patient will come with an ultrasound. It's very easy to get, is cheap. However, the ultrasound is very dependent on the person performing the study. So unless you have a very skilled sonographer that can help you provide a lot of detail of the mass or that is in question here, then it was not going to give you too much information. But if you have a skilled sonographer, you can help distinguish a solid versus cystic mass. You can see the area that has more flow, and this can also guide you for a biopsy. And the very skilled ones can help you tell and distinguish a recurrence versus scar tissue. Patients that are unable to undergo an MRI have CT scan, and we also obtain CT scan for staging studies. The staging studies are performed, as Dr. Patel mentioned, for CT scan of the chest, and in certain cases also at the abdomen and pelvis. PET-CT. PET-CT is a very modality that is jumping into attraction in the centers of cancer. However, it's a very expensive tool right now, and it's not indicated for all the sarcomas unless you have a baseline study. This will help you first for staging in certain conditions, and also help you identify if there's any kind of recurrence, especially in a patient that had a radiated field. And you can also see the response the patient underwent treatment, either radiation or chemotherapy, okay? But it's very expensive, and it's not every patient is as easy to get. And there's certain kind of sarcomas, such as myxosarcoma, that they're not useful to have this study. So after we have all the studies, we got the biopsy, and we try to identify this in the multidisciplinary team if there's a sarcoma, but if not, if the biopsy comes back positive and the image is suggesting for positive and the history and the physical exam suggesting for positive, so then we know it's a benign tumor. Then we can proceed by removing this mass with a marginal resection. And if it's a malignant condition, then we present this case in the tumor board, and then we have the multi-D team together to try to give the best the best option for treatment of the patient and avoid what Dr. Patel was talking about, having a patient with an unplanned excision. I want to take a minute for this. People think that biopsies are simple, and the reality is not. There's a lot of complications that can happen to biopsies, the patient undergoing biopsy, especially the person performing the biopsy is not clear about what is the track to do, where to take the sample, okay? Back in the days, a lot of biopsies were performed open, but hematoma contamination led to a wider surgical resection. And there's a big study from the University of Miami that Dr. Patel was part of it that evaluated core needle biopsy versus open biopsy, and they found that there was no significant difference between one and the other one in terms of recurrence. So less invasive core needle biopsy, and that's our gold standard now. But a good study from the Musculoskeletal Tumor Society in which they evaluated centers that were specialized in oncology and patients that were not specialized in oncology, and they found that the centers that were not specialized had almost a 20% chance of complications. That led to 18 patients undergoing amputations that were not necessary. So that tells you that this is important, to have a skilled pathologist have to perform a biopsy by a specialized person that knows what they're doing, and have the team evaluate this tissue. And it was 12 times better results for the patient if this procedure was performed by an orthopedic oncologist. So better outcomes for those patients. So these are an example of the type of resections that we perform in our oncology world. Benign tumors, you perform like a piecemeal fashion, but we perform a en-bloc resection, okay? So you have to go throughout the reactive zone. You don't have to remove a covered normal tissue. Malignant version, you do remove the mass covered with normal tissue around it, and you got to make sure that the tumor is completely surrounded by normal tissue and nothing is exposed. And in the case that there's a contamination, then we have to be more radical and remove a compartment, including vessels, bone, soft tissue, anything that's involved. After we remove it, benign lesions are 99.9% of the time closed primarily. And then there's a stage closure that Dr. Patel mentioned. We use a lot of the plastic surgery in our institution because these are not small incisions. These are not small surgery. This is like big surgery. And then most of the time, our preferred method is to do a delay wound closure. So we remove the tumor, we put we mark our margins, and then we place a wound back. And after that, we await the final pathology to make sure that the margins are negative. And once our margins are negative, the patient comes back in a week or 10 days, and then we perform the final closure if it's amenable for us, or if not, it is performed with plastic surgery. So in conclusion, we have to follow a guideline. We have to make sure that every patient that we encounter with this is treated the same way, so that way we decrease the chances of error. Patients should be referred to a tertiary institution, which are specialized in orthopedic oncology or musculoskeletal oncology, to decrease the chances of complications. Benign lesions are more common, as we mentioned, but not all tumors are benign. And we should recognize this malignance and refer them. We need to obtain the necessary images before we perform a surgery in our patient. And we need to combine this with our multidisciplinary team so we can provide our patients with the higher, not only oncological outcome, but with the highest functional outcome. I'm just going to go briefly over some examples. This is a 59-year-old female, as you can see in the MRI in the top corner up. It's a large mass involving the proximal thigh. She underwent a biopsy. It was a pleomorphic spindle cell sarcoma. Presented in the tumor board, the consensus was to undergo preoperative or neoadjuvant radiation. As we can see here, how this is unfortunately after radiation, she got burned in her skin. So that's how wide we have to go. We got to make sure we have some margin that we can avoid contaminating or spillage of this tumor around the wound. So this is how it looked after we remove it. It's a big defect, as you can see. So it was so large that we didn't feel comfortable with the margins. So we placed a wound back, and we awaited for final pathology. Once they confirmed it was negative, the margin, so plastic came by and closed it. This is another case of a young gentleman, 51, who had this mass in the leg that had been growing. It became very painful for him. He had a biopsy. It was a pleomorphic myxofibrosarcoma. These tumors are very tricky. They're very infiltrative. And as you can see in the MRI in the top and lower, it basically involved almost the posterior compartment of the leg. We presented on tumor board. The recommendation was to undergo amputation, but the patient was adamant about having amputation. He did not want to leave without his leg. So then we proceeded to recommend radiation and then salvage. This is how it looked after radiation. That's how huge the mass was. The lower part is the knee. The ankle is on top over there. And the next image, that is how after removal of the posterior compartment of the leg. And then that's the tumor over there covered with muscle. And then it was a stage closure by plastics. This is a young gentleman, 36-year-old male, who had a mass in the medial aspect of the distal thigh and the knee, growing for 2 years. It was a high-grade liposarcoma. He was presented at tumor board. He started with neoadjuvant treatment. Unfortunately, he was not responding to treatment, so we had to stop the treatment and then proceed with surgery. As you can see, the extent of the tumor from medial to lateral, and all the part of the skin is out from where the tumor was fungating. The knee is down here. And then we place a wound back after we removed that. And this is how it looked after it was removed. And then plastic came and finalized the closure. And range of motion is not great. It's from, I would say, from 10 to 80 degrees. But the patient is happy. He's able to go back to work and move around, and he has his limb. This is the most recent case that I did with Dr. Patel here. It was a transfer from Homestead Hospital. Unfortunately, this is a male with a very large mass. That is the posterior aspect of the shoulder. The elbow is down here. This is the shoulder on top. This mass has been growing 15 years. Unfortunately, it was neglected by the patient and the family members. And it was fungating. It was bleeding, fetid odor. It was diagnosed as a melanoma. So in order to provide, the patient was advancing and progressing, losing blood. So we did a resection of that huge mass. That was the large defect that was left behind. This is the scapula here, scapular spine. Okay, this is medial on that We placed a wound back as well, and we awaited final pathology. So we just got notice that it was negative this past Friday, so plastic is going to go and close it down. That's about it. Any questions? Thank you for your time.
Any questions? Sir?
Procedure, if any of these doctors would like to maybe present the case to tumor board with you for consideration of a case, minimums that you would require to present to tumor board, maybe even before surgery, MRIs, et cetera. Can you please expand? And how can we access tumor board from afar for those that are listening also?
Yes, so we have our tumor board committee. Patient will require to have the pathology, the slides. We need to see them by our pathologist. We need the necessary imaging studies, an MRI, and some staging studies, such as CT scan from the chest, and then have the slide, have a history of the patient. Sorry, and then once we get together, get all the data together, then we can coordinate and have present in the tumor board.
Any other questions? I have a question for you, Gio. What is the time, the turnover time for Papp? So after you resect that tumor and you're waiting for negative margins to the time where like some sort of soft tissue coverage occurs, what is the typical time?
It varies by the type of tumor.
Okay.
But I would say average, what, 10 days? More or less? 10 or 14 days.
10 to 14 days. Got it. Got it.
Question, what do you consider an adequate core needle biopsy specimen?
So depending on the images, and depending on the area where the tumor is, let's say, for example, you have a mass in the upper medial thigh, and you're not, the biopsy principle will tell you that you cannot go from lateral to medial to get a sample, despite that area being there. You have to go to an area where you plan where your surgical incision is going to be accordingly. And not only that, you need to look for the area that is more metabolically active. So that's going to give you the highest yield for the pathology. Usually the pathologists here are good with 3 or 4 core from a 19 gauge needle. So that's, if you look at it from your finger, and it's like a 2 millimeter or 2 thickness, and then they can take that to the lab.
So
question for the
let
same
me
thing.
let me finish with this. So the other thing that should be done is to whenever it's possible is to do frozen. So when you take the a core, then send it to frozen to see if it's diagnostic tissue. And also use the use of ultrasound also is important, because there are some tumors that are more cystic than solid, and then with the ultrasound you can identify solid areas where you should target the cores, no? But it's important, to have to be able to have diagnostic tissue, to be sure that you have diagnostic tissue, because if not, then the typical is non-diagnostic, and then you have to again, the patient try to reach out to him, and the problem is that many times these pathologists go outside for second opinions. So if you have a non-diagnostic tissue, then you can either repeat, or maybe the pathologist of your center will send it to second opinion, and then time is running there. So at the end of the day, you're repeating the biopsy 3 weeks after the first biopsy, and it's a vicious circle of timing. No?
I think you answered my question already. I was about to ask if you need to repeat a biopsy, what is the consideration of a frozen section on table? Frozen section biopsy on table. That's the one you're answering.
But also, regarding repeating biopsies, there is all years before, the gold standard was open biopsies, right? Nowadays we're shifting to core needle biopsies, even though the theory is that open biopsies you can get more tissue, etc. I mean, there are several studies that shows that there is similar accuracy, diagnostic accuracy with core needle biopsies. The problem is that, in those cases where you have non-diagnostic, results, then the question is, what should you do, right? If you have to repeat corneal biopsy or you go to an open biopsy. In those cases, it's important to maybe have a discussion in your multidisciplinary, group and see what will be the best for the patients. In my practice, I don't think it's a mistake. If you have a non-diagnostic corneal biopsy, I think you can repeat another corneal biopsy, making sure that you target solid tissue. If it continues to come negative, then or no diagnostic, then you can maybe try an open biopsy. But the problem is that usually in those cases of non-diagnostics are the cystic ones that have a lot of necrosis. So in those cases, when you're trying to do an open biopsy, also you can explode the tumor. No? So it's a little bit messy. So it's another issue that you should discuss with a multidisciplinary team, no, to have the best outcome for the patients.
All right, I think we're going to wind that down. Dr. Ribas and Dr. Papp have some closing statements.
Well, I think before we close it out, I think we need to hear from our folks, our friends, and then maybe you start the closing. And so I'd like to ask Dr. Minot and over here, if they want, and Andrew also, if you can say a couple of closing words, please. They can do it here at the podium if you like. That way others can see.
Good afternoon, everyone. On behalf of the Caribbean Orthopedic Association of Surgeons, I'd like to extend our sincere thanks to Baptist Health International for inviting, well, first to even put on this symposium. It has been an amazing experience. It started with a tour of the possibilities for orthopedic care at Baptist, and the tour was amazing in terms of the offering for tumor work and for advanced orthopedic work. And we from the Caribbean appreciated the effort put out by Baptist to improve the awareness of the possibilities here. For us in the Caribbean, Baptist Health has partnered with the orthopedic community for years. And that partnership has grown with the constancy being in a very open offer of support, both within the Caribbean and for selected cases for help for all patients overseas. We hope that that relationship will continue. And for this weekend, the talks put on by Dr. Cardoso and Dr. Papp have been very good. They've been broad. You've touched on various topics, which are wide-ranging, and we found it very applicable to our circumstances. A warm thank you from all of us. I'll now invite Dr. Amrali to give his remarks from the Jamaican Orthopedic Association.
Well, I would echo everything that Dr. Minot just said, so I'm going to keep it sweet and short. So on behalf of Jamaican Orthopedic Association, I would really like to thank you guys for inviting us. You've definitely shared a lot with us from an educational point of view, and definitely, getting to interact with the doctors, the surgeons, you guys, International Baptist. We really, really appreciate your support, and we look forward to collaborating more and more with you, and definitely So we enjoyed the education, the collaboration, and the socialization. So thank you on behalf of the Jamaican Orthopedic Association.
And we could not do this without the academia. So Dr. Papp and Dr. Cardoso, some closing words, please.
So thank you to Roy. Thanks for everyone for coming. That's both everyone that's coming from Jamaica and then our faculty that came, took a day off on their Saturday. So thank you, everyone. Thanks to the international department. Thanks to everyone who's listening online. Yeah, hope you guys have a wonderful day, and hopefully we'll see each other soon.
So, like Andrew, I'm going to keep this short and sweet. That was my nickname in high school, by the way. Just kidding. It's again, I really really enjoy the interaction, the collaboration. I've met all of you before, and it's such a pleasure to have you here on our home turf. And I hope that we continue to grow this because I think it's invaluable. So thanks so much for coming. Appreciate it.
And so also I'd like to thank all those that have been online. Dr. Kwan Soon, Ticos, sent us a shout out. And so we have some of our folks from Trinidad that are logging in as well. And so more of this to come. We think of this was the first pilot. And what Dr. Papp and Dr. Cardoso don't know is that be careful what you start, right? So more to come. But we really want to thank you for being here with us. I think our foundation of our business and international is relationships. If we cannot have a relationship, we really don't have anything. And I'm really proud of the work. Thank you to Dr. Paralitishi, Dr. Patel, all the doctors that helped out today too. These folks taking their time from their families to come and spend time with us. We really appreciate you all and what you do. And so with that, hopefully we can make this a bigger symposium later on, and you all can help us take the lead, and then we can bring other folks from the Caribbean here and make it some kind of a bigger. I know the marketing people are already giving me the stare, right? Because I'm going to complicate their life. With that, though, I want to thank you all so much. And look, you have friends here. I hope you feel that you're at home, and anything we can do to help in any way, just reach out. For those that are online, any questions for the doctors, we have an email, which is bhiwebinars@baptisthealth.net. It is bhiwebinars@baptisthealth.net. It will be posted now in the chat. So any questions, we can get them over to the doctors. And with that, I hope everybody has an amazing rest of the day, and thank you so much for your time. Thank you.